ക്യാമറ ഓണൊക്കെ തന്നെ.
Stop video. Stop video.
Stop video. വെക്കാം.
Hi Nelby.
Hi sir.
എല്ലാവരും ജോയിൻ ചെയ്യുമല്ലോ അല്ലേ? പറഞ്ഞിട്ടുണ്ടല്ലോ അല്ലേ?
എല്ലാവരുടെ പറഞ്ഞിട്ടുണ്ട്. മുരളി എല്ലാവരെയും വിളിച്ചു, വിഷ്ണുവിനെ വിളിച്ചു. ഇനോഗ്രേഷൻ കഴിഞ്ഞാണോ എല്ലാരും ജോയിൻ ചെയ്യാന്നുള്ളതാണ്.
അത് കുറച്ചുപേരെ എങ്ങനെയായിരിക്കും. രഞ്ജൻ സാർ വന്നിട്ടുണ്ടല്ലോ. ഹലോ സർ, ഡോക്ടർ രഞ്ജിത് പെജാവർ. I think he has not joined. Madam, good evening.
Good evening.
Long എന്തൊക്കെയുണ്ട് മാഡം വിശേഷം?
സുഖായിരിക്കുന്നു.
ലോങ് ടൈം. ഇങ്ങനെ ഒരു ഫോറം കിട്ടിയല്ലോ അല്ലെ, അറ്റ്ലീസ്റ്റ് മീറ്റ് ചെയ്യാൻ.
അതെ അതെ, എല്ലാരെയും കാണാൻ പറ്റുമല്ലോ.
അതെ അതെ അതെ.
എങ്ങനെയുണ്ട് നമ്മുടെ ഡാൻസ് പ്രോഗ്രാം ഒക്കെ?
ഒക്കെ ഗോയിങ് സ്ട്രോങ് മാഡം. മാഡം ജോയിൻ ചെയ്യും. നാളെ ഉണ്ട് മോർണിംഗ്, എവരി സൺഡേ മോർണിംഗ് 7:30 ഉണ്ട്.
ആണല്ലേ? അത് ശരി. എനിക്കെന്തായാലും യോഗ ഉണ്ട്, അതുകൊണ്ട് ഞാൻ
യോഗ അല്ലേ? ഓക്കെ,
അതുകൊണ്ട് മാറാത്തതാ.
ഓക്കെ.
സുമ ചെയ്യുന്നുണ്ട്
ഉണ്ടല്ലേ? ഓക്കെ ഓക്കെ.
സുമ കുറച്ചൊക്കെ കുട്ടികളെയും കൂട്ടി.
അത് ശരി. അപ്പൊ പിള്ളേർക്ക് ഇൻട്രസ്റ്റ് ആയിരിക്കും അല്ലേ?
പിള്ളേർക്ക് ഇഷ്ടമാണ്. ബ്രസ്റ്റ് മിൽക്ക് ബാങ്കിങ് എങ്ങനെയുണ്ട്? നന്നായിട്ട് പോണില്ലേ?
കുഴപ്പമില്ല. ഇപ്പൊ ആക്ച്വലി we are having ഒരു എക്സ്ട്രാ 6 liters ഒക്കെ പെർ ഡേ എക്സ്ട്രാ വരുന്നുണ്ട്. ഇപ്പൊ ഞാനിപ്പോ ഫോമിൽ ഉപയോഗിക്കുന്നില്ല, ഇതിനകത്ത് ഇപ്പൊ ലെവൽ 3 അപ്പൊ സംതിങ് വെരി എൻകറേജിങ് ആക്ച്വലി. ഇനി അതിപ്പോ ഇവിടെ നിന്ന് മാത്രം ജൂബിലിയിൽ മാത്രമേ ഉള്ളൂ. വി ഷുഡ് എക്സ്റ്റെൻഡ് ഇറ്റ് ടു ദ അതർ പ്ലേസസ്. അത് ഒന്ന് അതിനുള്ള പ്ലാൻ ആണ് ഇപ്പൊ. ലൈക്ക് വിഷ്ണു മസ്റ്റ് ഹാവ് ടോൾഡ് യു അല്ലേ?
പറയുന്നുണ്ട്.
ഹലോ ഡോക്ടർ സുമ.
ഹായ്.
Good evening. Sir, good evening. Ranjan sir.
Good evening, Manoj. How are you?
Thank you for joining before time.
My pleasure. I thought it was 4, so I have joined at 4 o'clock. Don't worry.
Anyway, 4:30, sir. I mean, it's now time. Another 2-3 minutes only.
I know. I was wondering why Dr. Ranjan said I'm already in the meeting.
It's a honor to have him 5 minutes early.
No, I have not reached such a stage still, Manoj.
I know you are. Well, I must be hopping from one meeting to another.
I am a simple Ranjan Kumar.
No, you have only 24 hours, so you have to hop around.
Well,
NLB Ravi sir. വിഷ്ണുവിനെ ഒന്ന് വിളിച്ചോട്ടോ.
Dr. Suman?
Yes, sir.
So the Maharashtra Goa is happening sometime soon, isn't it?
So that is the next weekend.
And Dr. Ashish is trying hard for Gujarat.
Gujarat, yeah.
That
So
is
that will complete, I think, all the
yes,
states.
we can sing the national anthem.
Oh no, my God! All the states completed. This is excellent.
All the states, every state. Detect has completed all the states today.
Great. This is actually a great achievement for Suman and
Quality initiative. Today, the last zonal meeting, 6 zonal meetings.
Only
Yeah.
Northeast, we did it all together. We had one in Assam. And I think only state is Jammu and Kashmir we haven't had.
Suman.
Acha.
And
Yeah.
it's disputed area, Suman. It's okay. Actually, we
Maybe-
shouldn't say that. But then Equip is finishing on 3rd December, all that 11 modules.
Mm.
So everything will be over, Manoj.
It's
God
Herculean task. Really, like nobody has done this so far. So really, like we should honor you there in the.
No. My happiness is that we involve the states. That I'm pleasantly what do you call as proud about that, involving the states. See, doing it from the center, there is no ownership.
Correct, sir. This way, this is a very good strategy. Very
And
nice
doing
strategy.
it in like we did Sath in only metropolitan cities and big cities. This is the whole state.
Correct. So that is, there is no doubt about it. This is unparalleled, and there like more and more activities like this will come up now. Actually.
No, but the best part is I had a good backing of veterans. Veteran in program management and this thing. What is that? Event management, like you, Suman, Ashish, MKC, and Naveen Jain.
So the credit is to you. You have tapped all the people, and then it is not that everybody is there, but was there all the time. But then somebody has to be there to take the lead. That you have done.
The Noel also, Dinesh Chirla, Manisha Vandankar. The tappable energy in NNF is enormous, and if one understands that, it will be fine. Hi, Dr. Ravi.
Hi, good evening, sir.
Hello,
How are you?
Vishnu. Hi.
Hi, sir. Good evening. Good evening, sir.
Vishnu.
Dr. Ajit, welcome. Thank you so much.
Now the NNF today is being run by Vishnu.
So Dr. Ajit is the president of KFOG, Kerala Federation. Like Dr. Ajit.
That's very nice meeting him in this forum. of MILAN.
And Omana Madam is one of the senior obstetricians in the state.
She is the next
Oh.
vice president of K4G.
Okay. She doesn't require positions, I think.
So nice to see you, Dr. Ajit.
Thank you, sir. Nice to see you.
Is Faisal who is from Kerala?
Yeah,
Yes.
Yeah, he's our EB member. He's the
I know.
obstetric representative for our EB.
He's a good friend, actually.
He is from Cochin, sir.
Cochin. Okay. I mean, he has promised to come to Bangalore.
Yeah. He is working in Amrita, AIMS.
Ah.
ലീവ് ചെയ്യേണ്ടി വരും.
And all the zonal neocons held, Manoj, for the first time in the history of NNF.
That's what. No, there are a lot of feathers to cap. Now the cap has no more place to keep.
Nothing like that.
No, there are so many firsts with you, so it is really, like.
It was a really wonderful year.
I know, like, totally,
Vishnu, how is the work going on about the NNF today?
Yeah, sir. Compiling data now.
Has Dinesh Tomar sent you the requisite material?
Yeah, he has sent me his report, sir. Annual report, which has everything.
And with the photos and all.
Yeah, photos are there. And many, I think, our last two editions, photos are still with me. So we just need to compile all those.
Okay. And Manoj, you have Zumba sessions in Bangalore, no, every day?
Not planned as it is.
Like important. There's a big hall there.
I know we had in the South Neocon. We had at that time. We had this time. We not planned anything.
Start planning. That comes in the non-academic events, which is very important for a human being to blossom.
We can at least every day people may not be there. At least one day we can plan. Like
okay. Second day would be the best. Because third day post banquet, many may not be perpendicular to the ground.
Correct.
Early in the morning. I mean, later on there.
Only the timing we can discuss this, sir. What time we want.
Yeah, we can discuss this. Yes.
He is always ready.
Fitness anytime ready, sir. Anytime ready.
Give him a face, he will do it.
Sir.
It's almost a national program now.
Yes.
Because there are so many states affiliated. And the best part is the abbreviation is NNF only.
Yes, but we have a lot of people from the other specialties. Even the endocrinology, cardiology, and obstetrics. A lot of other specialties doctors are there, basically. And their families also.
Okay.
But so mainly NNF. Mainly NNF.
You have fans across specialities, across country.
It's not my this thing, sir. Come on.
So,
yeah, sure.
Dr. Ajit, Dr. Venugopal will be coming up.
I think he has some problem with the connections.
So, like,
Dr. Fesi also will be joining. He's in Calcutta actually.
Anybody else from the during the inauguration? Anybody else from your side?
Omana Madam is there. No?
Madam is there. Madam is there. Yeah. Dr. Suman, when are we starting? What is the plan? Like 30 or?
Oh, first of all, anyway, I'll say that later.
Sir.
So shall we start?
Suman, Dr. Suman, are you there?
Yeah, I'm here.
Yeah, okay. Nelby?
Shall we start, sir?
Yeah, Nalvi is here.
Okay, sir. So who is going to take it, sir?
Hello, Bisht. I'm in the Milan, Kerala. Okay, I'll call you.
Dr. Suma, shall we
You
start the
call
program,
me
Dr. Suma?
sometime, when you are in the car. Yeah. Okay.
But the time that was given in this thing was 5 p.m. Is it okay to start now?
No, that is the session, no? Inauguration is 4:30.
Session, madam. Inauguration
That is
at
4:30.
4:30.
4:30, no? 4:30 was the time given, no?
Yeah.
Yes.
Nelby, who is starting?
Dr. Suma is starting. Yes,
You have the list and all, no? Program list and all. So,
yes, I have sent to JV, sir.
Inauguration list. I don't have the that inauguration
I
ceremony.
have sent.
No, I can
I
start
have
it.
sent to JV, sir. Sir, can you send, sir?
Yeah, I can.
It is there in the group, and according to that, the starting is by the welcome address by Dr. Ravi.
Okay.
so
I think I will take over this part.
Good evening, sir.
So shall we start?
Thanks, sir.
So good evening, ladies and gentlemen. A warm welcome to Milan Foxg NNF Perinatal Meet 27th, 28th November 2021. NNF Kerala is privileged to host the Milan Kerala, which is a harmonious blend of obstetricians and neonatologists aiming at the best outcome for the mothers and the best neonatal outcome. That is all what we aim at. So I'm glad that I've been entrusted with the pleasant task of welcoming all the participants to this novel initiative. At the outset, I express my gratitude to our beloved National President, NNF, Dr. Ranjan Kumar Pejawar. He is the doyen of neonatology of our nation. A warm welcome to you, sir.
Thank you.
I'm glad to welcome Dr. Ajit KF4G, President of Kerala State. A warm welcome to you, sir. A great pleasure to welcome Dr. T.P. Jayaraman, IAP President, Kerala State. I also welcome Dr. Fessy Lewis, Vice President, FOXG of Indian chapter. He is the National Vice President. He will join us shortly. I understand from Calcutta.
he's there already. He has joined already.
I am here, sir.
Warm welcome to you, Fessy. I am delighted to welcome Professor Suman Rao, coordinator of the Milan program of the day.
Thank you, sir.
A warm welcome to you, madam.
Thank you, sir.
I welcome Dr. V.C. Manoj, South Zone EB member, NNF India, and the backbone of NNF Kerala.
Thank you, sir.
I'm delighted to welcome Dr. Vishnu Mohan, the vibrant IAP Perinatology Chapter Chairperson. He is
Thank you, sir.
our source of strength. A warm welcome to you, Vishnu.
Thank you, sir.
I'm delighted to welcome Dr. Venugopal, Secretary, KFOG. I think he is yet to join. Last but not the least, I forgot Omana Matsudanan, Madam, from Wayanad. A warm welcome to you, Madam.
Thank you.
And we welcome the entire faculty who have been kind enough to participate in this program and enlighten us with their talks, which is forthcoming. I welcome Secretary NNF Kerala, Nelby George Matthew, who is my right hand.
Thank you, sir. Thank you, sir.
Welcome, Nelby.
Thank you, sir.
I welcome entire team of faculty as well as the chairpersons who are participating in this academic feast. Thank you very much. And I wish the program all success. Now, the inaugural function. Dr. Ranjan Kumar Pajawar, National President, NNF. Over to you, sir.
Good evening, all my friends from pediatrics, neonatology, and obstetrics and gynecology. Very good evening and namaste. Now, first, let me congratulate the Kerala NNF chapter for bagging the Best Chapter Award for 2020. That was great achievement and it is a well-deserved award. My dear Dr. T.V. Ravi, NNF President, Dr. Nelby, Secretary of NNF, Dr. Ajit, KFOG President, Dr. T.P. Jayaraman, President of IAP, and Dr. Venugopal, Secretary of IAP. Dr. Fessy Lewis, we have not had the opportunity of meeting person to person this year. Am I right, Dr. Fessy?
Yes, sir. Yes, sir.
And I hope we will get that opportunity in December. Please do come to Bangalore. Good weather, good hospitality, and good academics. That is my request and invitation for the Gynae. He's also an EB member. He's the representative of Foxy in our executive board. Dr. Vishnu Mohan, as we know, he's the young, budding, rapidly progressing neonatologist from Kerala. He has been actively involved in NNF Today, which is the compilation of whatever little we do from quarter to quarter. And the other important thing is he's a perinatology man in Kerala. He's currently the IAP perinatology chapter chairperson. So that is something which I'm very happy that in Kerala, even much before all the others thought of perinatology, they have been practicing it. It is very, very important that we have a very smooth and cordial and proactive connection with each other, the pediatrician / neonatologist and the obstetrician, because ultimately it is the we are looking at the good outcome of the mother and baby dyad. Now, from the perinatology point of view, I would like to inform you that the first national level perinatology conference was held in Gurgaon just few days ago with the active collaboration with the Foxy. Dr. Shantakumari was very great and I was very happy at the encouragement she provided. She sent her vice president from the north, Dr. Archana, at the function, and the function went on very well. The conference was good. I like the topics they selected, like examination of the placenta and many other very innovative topics, which was very, very belonging to that perinatology or perinatal medicine syllabus or subject. The idea is to continue this every year There are perinatology meetings in cities and some states like Kerala, but the national level perinatology meeting with a promise of continuation, I think this is the first one. Next year, it will be hosted by Foxy. That way we are going to alternate 1 year NNF, 1 year Foxy. The other thing I want to inform is we brought out the COVID clinical practice guidelines for the management of mother and newborn, which was hailed as one of the best guidelines. Acta Pediatrica voted it as the best guideline among the 19 or 20 countries which submitted their own guidelines along with India. An article of that has been published in the electronic media of Indian Pediatrics, and soon you can see it on print also. Now, the other thing which is going on, hopefully it will have a happy ending at the Neocon, is the book Protocols in Perinatology. Dr. Vishnu Bhatt and Dr. Ashish Jain have taken the lead in as editors-in-chief. It's got more than 50 chapters and about 120 authors. And each chapter is co-authored by an obstetrician and a pediatrician/neonatologist. So it is a true representation of perinatal medicine as it should be. So that we hope will be finally ready and released at the Neocon. So these are some of the things we have done. Last but not the least is MILAN. I am happy to say this is probably the penultimate program of MILAN. I think one more in Maharashtra, Goa next week, and one more during the first week of December in Gujarat completes the entire agenda of MILAN. Every state it has been held. And the beauty of this is it has been held in every state with very good cooperation between the Foxy and the NNF. The standard of the meetings have been quite high. And to churn out a program like this of good standard consistently and constantly is not an easy job. And that has been done by Dr. Suman Rao, Dr. Ashish Mehta, and many others who have strived hard. And in all the meetings, the Foxy and IAP and NNF have joined hands together, which is the real definition of collaboration. And only with this, we can at least hope to achieve the INAP goals in 2030. I see a lot of senior people here, Dr. Omana, Dr. Parvati, Dr. Tony Mampille, Dr. Amrita Madam, various people are there. And I'm sure this MILAN, Kerala, is going to be again of a very high standard, and there will be ample scope for exchange of ideas, sharing of experience, and learning from each other, which is the very philosophy of the MILAN programs. And MILAN, I'm glad to say, has gone international. MILAN Bangladesh was held. MILAN Bhutan was held at the request of the respective societies from there. And MILAN UAE was also held. And there are a couple of requests like Nepal and Cambodia. We will look into that, in the coming year. So with these words, I thank all the people who are responsible for this MILAN Kerala, and all the people who are responsible for the MILAN program in general, nationwide. And I wish the MILAN Kerala a grand success. Over to you. Thank you.
Thank you, Dr. Ranjan. I would like to invite Dr. Ajit K. Fuji, President, to address the meeting.
Good evening, all. Respected President NNF, Dr. Ranjan Kumar Java, Vice President Foxy, Dr. Fessy Louise, past Vice President of Foxy and the Senior Obstetrician, Dr. Shekaran Sir, President of NNF, Dr. Ravi, President IAP, Dr. Jairam, Dr. Suman Rao, Coordinator of MILAN, Dr. Manoj BC. Actually, he is coordinating all the activities. He is responsible for this meeting. Dr. Venu, Secretary KFOG, Dr. Vishnu Mohan, Dr. Nelby, senior faculties, dear friends. As Dr. Enchan mentioned, the perinatology is an emerging subspecialty. Actually, even before national conferences, the state of Kerala was conducting this perinatology meeting. And it's quite happy thing that the first national meeting happened in Gurgaon. And I think the second meeting, since it is going to Foxy, I think Dr. Fisi Lewis can take initiative to bring it to Kerala because we are ready to host it. I request him to do that. We could reduce perinatal mortality very much compared to other states in India. In Kerala, we could reduce it. But to reduce it further by even 1 to 2%, it needs much efforts from both obstetricians and the neonatologists. And we all know it's a quite devastating experience, both for the parents and the physicians, to face unexplained and unexpected stillbirths. We need better technologies and clinical expertise to predict it and time the delivery according to it. Today and tomorrow, we have excellent faculties to discuss different aspects of perinatology. I take this opportunity to thank all pediatric colleagues, especially Dr. Manoj, Dr. Devi, and Dr. Nelby for organizing this webinar. I hope next year we will be able to make this conference physically. Best wishes. Thank you.
I just forgot to mention the all-rounder and evergreen VC Manoj's name. And sorry for that. And as you rightly said, he is there where action is there. And action is there wherever he is there. So the next, after his March conference of IAP Neocon, I think Dr. Fisi Lewis should take up the idea which Dr. Ajit has forwarded, and you have stalwart organizers to do that maybe in the month of September or October before the conference season actually begins. Thank you.
Thank you, Dr. Ajit. Now we move on to Dr. T.P. Jayaraman, IAP President, Kerala.
I think he is set to join.
Okay, then we'll move to Dr. Fisi Lewis, Vice President, India, Foxy, for his address.
Good evening to you all. Sorry for the audio connectivity. I am in Calcutta, but I am happy to be seeing this meeting coming to light. Even though perinatology meetings has been organized before you, even 3 years back itself, we had one in not even in big city in Saltam Batteri. Omna Madam will be knowing how we conducted there. So like that, perinatology meetings are there, but as a national level, as a Foxy with the Shantakumari Madam and Anjan sir, we took initiative, as sir told, to organize 1 year by Foxy, 1 year by NNF to organize national level meeting also. And I'm happy to be associated with all the vibrant people nationally and also in the state also. As you all know, to tell you one example, is that in Kerala, we started a human milk bank, and everything started during Manoj's time and completed during Ravi sir's time. One in the government hospital side in General Hospital Cochin, one in Thrissur, Jubilee Mission Hospital we have started, and it was a costly thing. So you need to know how much effort we had to do the mobilize, and with the help of Rotary Club of the Rotary district. And also the 2 Rotary clubs in Cochin Global and the Thrissur Central, we started it. So, and as you all know, this has to be run, if to run, you need to have a good neonatology support and guidance from the Foxy gynecologists also. That is what we are aiming. We are aiming to do that in a few more cities in Kerala. If you get a few sponsors to fund the milk bank, and the running part, neonatologists will be there, and the motivation part, all the gynecologists will be helping to do. this is just an addition or continuation to the academic things what gynecologists and neonatologists are doing. I think this will be a role model how the collaboration between neonatologists and the gynecologists for all the entire country. And this meeting will just an example of how the things will be. So I wish all the success for this meeting and coming meetings of collaboration meeting NNF and Foxy, all the other states and the all India level also. Thank you.
Thank you, Dr. Fessy Lewis. Next, we'll move on to the introduction to the concept of MILAN by Dr. Suman Rao, Coordinator MILAN.
Respected President Dr. Ravi, Dr. Ajit, Dr. Fessy Lewis, Dr. Ranjan Pejawar, and my dear friends, Dr. Manoj, Nelby, and everyone. It's indeed a pleasure to have this meeting in Kerala. And in fact, Kerala, we were supposed to be here in July, but I'm glad that we are here in November now, because Kerala is very vibrant with meetings. To find an occasion, a weekend to have a meeting in Kerala is a tough challenge. And thanks to you all, because I think the care as well as academics is what has taken you all to the single digit NMR, which you have already achieved. And that is actually the goal of MILAN. The way MILAN is planned is to have the obstetricians and the pediatricians come together on a common, nice platform where the recent advances in both the fields are discussed together. And the whole focus is to ensure that our nation reaches a the sustainable development goal of reaching a single digit NMR by 2030. And in fact, this concept of MILAN was started in way back more than a decade ago when Dr. Ranjan was president of NNF Karnataka and I was a secretary. We had a joint perinatal meeting, which was so well attended that we had to limit registrations and have a part 2 a few months later. And then it got transformed into Saath under his guidance as president of IAP Neonatology chapter. And then finally, as NNF president, Dr. Ranjan has taken it to scale internationally, where we have obstetricians and pediatricians deliberate together. Initially, it was a one-day conference, but to adapt it to the virtual world, it is now on 2 days, 2 afternoons, or afternoon and morning. And the subjects or the sessions which are chosen are all designed to achieve single-digit NMR. The focus is on prematurity. The focus is on asphyxia and its prevention, and also prevention of infections. And I'm sure this has brought the two academic groups together, and we are all set to work together, as we all have seen with the COVID guidelines and with this new perinatology conferences. I'm sure both in academics as well as in care, we will be together, united. We will be MILAN together to improve the outcomes for our mothers and newborn. Thank you very much, and I wish this program a grand success.
Thank you, Dr. Suman. Now we move on to felicitation by Dr. V.C. Manoj, South Zone Executive Board Member.
Respected Presidents, Dr. Ajit, KFOG, Dr. Ravi Sir, NNF, Chief Guest, Dr. Ranjan Pejawar Sir, my dears, the respected seniors, Shekharan Sir, Omana Madam, Tony Sir, and all my dear friends, Dr. Suman, Dr. Vishnu, Dr. Fessy, and all my dear other friends. It is again, MILAN is again the first national perinatology meeting we are having in our state, even though we have been having this for some time, and then this is the second perinatology meeting this year we're having. But it's a real honor to have the national, to give a national color to this. And as was rightly mentioned by Dr. Suman, the IMR is what we actually the philosophy behind the whole thing. And then even though our national figures are still 23 and all, it has come down to 23, but and our figures are much low at 5 or 6. Now to bring it down further, a common dialogue is mandatory, and that is the way to go. So the dialogue between the caregivers of the mother and the baby is the only way to bring it down further, or one of the most important ways to bring it down further. So in that, I think we are doing the right steps. We had a massive or rather a hugely successful perinatology meet, physical meet, the last before the COVID stuck in Wayanad, organized by Vishnu and his team. And after that, in the COVID, probably we were initially slightly inactive with the perinatology aspect, but then again we started now with Dr. Ajit's leadership. Now it is going to the next level, and Dr. Fezzi is there at the national level. So let us hope that now more the national meet next year will be brought here by Dr. Fezzi, and then let us take it to the next level. Now, I want to really thank Dr. Fessy Lewis, who is a good friend of mine, for doing something more for perinatology, something that is unique for Kerala. He is the one who helped us enough to establish the breast milk bank with his Rotary connections, to establish the first 2 Rotary milk banks in the state. And today, I am very proud to say that today I have 6 liters PDHM extra. So this is the state for the last 2 weeks. We have been having extra milk in our PDHM. Now in my hospital, I can't use it further. I want to distribute it. So we need the next system of collection and distribution centers in breast milk. And this is something again Rotary has promised to help us. We need to go on fast track now before the momentum is lost. Now we had 2 breast milk banks running, and then now when you have, so far the complaint I always had till last month was that my demand is much more than the supply. I am not getting enough milk, but now we have been able to mobilize so many mothers and we are getting milk. Now let us utilize it. Let more and more babies benefit. And why am I stressing this point in this meet is because this is the forum which will actually give a fillip to this. Until we motivate the mothers to donate breast milk, the program won't be successful. And we have been, the initial discussions we had in Wayanad, and then the the KFOG is totally with us in this. Paili sir at that time, if I remember Paili sir's remarks. So probably this is something that we should do together as a project other than having meetings. So I would request all our respected KFOG colleagues to kindly lead or associate with us and have collection and distribution centers wherever it's feasible. 2-3 hours of journey is feasible, so that more and more preterm babies can be benefited with the breast milk bank that we have. I will not take much time. So I really want to congratulate Dr. Suman and Dr. Ashish Mehta, 2 of the leaders who were actually spearheading this MILAN this year, and then they had done the incredible task of completing it in almost all the states before the national neocon. It's a huge task. So now hearty congrats Dr. Suman and Dr. Ashish for that. And I really thank all my dear friends in NNF Kerala who have been supporting all the activities of NNF Kerala. And now we have our close associates, the KFOG, and then of course the IAP. So we can all three, these 3 organizations can move together so that we will now, it is a huge task to bring down the IMR from 5 or 6. But then if we all walk together, we move together, probably we will be able to achieve. And then we need to plan now. Just meetings alone is not enough. We need action now. So that is what we should plan in the next phase. Thank you so much.
Thank you, Dr. Manoj. We move on to Dr. Vishnu Mohan, IAP Perinatology Chapter Chairperson.
Respected President Ravi sir, Ajit sir, President KFOG, Ranjan sir, President NNF, seniors and dear friends.
it's really great that all three stakeholders of perinatal care, KFOG, NNF, and IAP, has come together on a same platform today. And it's really important, as our previous speakers were mentioning, for the optimization of outcomes. I congratulate Ranjan sir and his team at Central NNF for making perinatology one of his focus in his action plans. And I also congratulate Ravi sir, Ajit sir, Dr. Venugopal and NLB and team for the wonderful organization of meeting today. Wish all success for Milan Kerala and wish you all a great learning experience. Thank you.
Thank you, Dr. Vishnu Mohan. Let us move on to Dr. Venugopal, Secretary, KFOG. Yes, not joined.
Not coordinating.
He has some problem with the connection. He is waiting for the flight or something.
So, shall we move on to the next vote of thanks?
No, Omena madam is there, no?
Omena madam. Yeah. Omena madam.
Good evening to all the respected dignitaries on the dais and all who has logged in. It is my great pleasure to address you all today in this inaugural function. As previously told, we have organized a very successful perinatal meeting in Wayanad, physical meeting a few years ago, and we are very happy that all the faculties, almost I see here, were present on that occasion. I'm sure you will all have a very good learning experience today, and wishing all the best for today and tomorrow's webinar. Thank you.
Thank you, madam. Now, shall we move on to vote of thanks?
Dr. Ajit, anybody is there from KFOG?
Jagaran sir is there. Sir,
Jagaran.
want to say something?
Yeah.
He is the senior most person.
Yes, yes. Shagaran sir.
I think sir is there. Sir, you are muted.
So please unmute, sir.
I am happy to see that both pediatricians, neonatologists and the obstetricians are together trying to bring down the perinatal mortality and especially the neonatal segment of the perinatal mortality. We as obstetricians always look forward to the help of neonatologists, especially when we are having a newborn who is preterm or FGR. And these are the two groups of babies which we are losing or having morbidity afterwards. So I'm very happy to see that we are on the right track, joining together, and hopefully we'll bring down further the perinatal loss avoidable, which is very much needed. And I wish all the best for this program, and I am eagerly waiting to learn from this meeting. Thank you very much.
Thank you, Dr. Shekharan.
Tony sir is there, past state president.
Dr. Tony Mambili, would like to invite you for feliciting the.
So please unmute.
Thank you, Dr. Suma. At the onset, let me express my gratitude for inviting me to offer a felicitation. My friends, all the friends, right from Dr. Ranjan Pejawar, Manoj, Ravi, all are there, and Dr. Suman Rao. So I think it is indeed great. These are things that once we were hoping and planning to do maybe a decade or 2 decades ago, but now it has all come to a reality. And I am really happy to know that the NNF is doing a lot to bring down the neonatal mortality in our state, and we are all proud. I mean, we all should be proud of the work that we are doing, and I wish all the success for this conference. Thank you.
Thank you, Dr. Tony.
Let's proceed, Suma.
Yeah, and then let's move on to the next session. That is a vote of thanks by Dr. Nelby Matthew.
Thank you, Dr. Suma. Good evening, everyone. It's indeed a great pleasure to see the obstetrician and neonatologists in the same platform to share their views to improve the neonatal outcome. So, first of all, I would like to thank the Central NNF and FOXI for joining their hands for this great initiative. And I thank our NNF National President, Dr. Ranjan Kumar Pejawar, for this presidential action plan and also personally inaugurating this MILAN 2021, MILAN Kerala 2021. Then I thank Dr. Fessy Lewis, Vice President FOXI, for gracing this occasion with your presence and also kind words. Thank you, sir. This CME materialized because of the guidance of MILAN coordinator, Dr. Suman Rao. Thank you, madam, for your guidance and kind words, madam. Then I thank the presidents of IAP Kerala, Dr. T.P. Jayaraman sir, KFOG President, Dr. Ajit, and my own leader, NNF President, Dr. T.V. Ravi, for joining hands and cordially conducting this CME program. Thank you all. And I would like to thank our own Dr. V.C. Manoj, South Zone EP member, as everyone was mentioning, is the inspiration for all the activities, absolutely all the activities in NNF Kerala. Thank you, sir, not only for this program, but for all the supports rendered to us. Then I would like to thank Dr. Venugopal, KFOG Secretary, and Dr. Vishnu, my good friend and IAP Perinatology Chapter Chairperson, and Dr. Murali, my team member, and NNF Treasurer, for all the support rendered for materializing this CME. I take this opportunity to thank all the seniors who are attending this program and all the faculties who had readily agreed to take up their job, and also the chairperson, as well as all the delegates who had come to attend this CME, who is virtually attending this CME. Thank you all.
Thank you, Dr. Nelby. So with that, we have come to the close of this inaugural meeting. Thank you for joining us.
Let's start now, Nelby.
We'll straight away start. Yeah. Dr. Suma, shall we move on to the academic session?
Okay. So I would like to thank everyone for joining the meeting today, MILAN and NNF FOXI Joint Perinatal Meet, organized by NNF Kerala, KFOG, and IAP Perinatology Chapter. I hope you all will enjoy the wonderful academic feast, which includes discussion on common perinatal problems that we encounter in our day-to-day practice. We have a group of excellent speakers who will enlighten us by sharing their vast experiences with us. Let's start the first session of this evening, Obstetrics for Pediatrics. I would like to invite Dr. Simi Kurian, Associate Professor of Obstetrics and Gynecology, Pariyaram Government Medical College, and Dr. T.V. Ravi, HOD, Pediatrics and Neonatology, Ernakulam Medical Center, and Kerala State NNF President, to chair this session. Over to you, sir, madam.
First of all, let me thank the organizers of MILAN, NNF, KFOG, and IAP Perinatology Chapter for giving this opportunity to be a part of this wonderful webinar. and I am sure it will be an academic feast. And to begin with, we have the session, as said, the obstetrics for the pediatrician. And we have the 3 excellent topics and 3 wonderful speakers. Can we move on to the topic?
Please proceed.
So first topic is fetal surveillance Doppler. And it's a very relevant topic as almost all the pregnant ladies undergo Doppler study as a part of the growth scan around 32 to 34 weeks. And if any abnormality, again, the further surveillance using the Doppler. And to deliver this topic, we have Dr. Lalitambika. Madam is the president of Alappuzha ONG Society. And Madam is a past head of the department, Government Medical College, Alleppey. And also, Madam was the KFOC past president. Over to you, ma'am.
Madam is not seen here.
Will we have the next talk, and by then we can call her or something? So to avoid wasting time.
Serena, madam, is there, I think?
She's here.
Okay.
Serena madam is there.
Okay. So shall we move on to the next topic then? Okay. So, we will move on to the topic, the intrapartum monitoring. And to deliver this topic, the importance of intrapartum monitoring and what all things we should know, we have a wonderful speaker, Dr. Serena Gilvas, a great academician, a great teacher, an excellent surgeon. And we all love to hear from Madam always. So over to you, Serena, Madam. And to introduce Serena, Madam is the head of the Department of OBG, Jubilee Mission Medical College, Thrissur. And Madam is the President-elect for the year 2022 for the Kerala Federation of Obstetricians and Gynecologists.
Can you hear me?
Yes, ma'am.
Okay, then it's okay. I thought I was not heard. Okay, right. But I guess you can't see me, no? I don't know why.
We are seeing the slides now.
Why enabling video?
No, I don't have any video, but it doesn't matter.
Like your video, no, you are not visible.
I don't know why I'm not visible.
Okay.
Ma'am, your video is off, I think.
അതെങ്ങനെയാ ഓൺ ആക്കാൻ? Better stop all this. No, it doesn't matter. I'll just go ahead with this, okay?
Okay.
Okay. Good evening, everybody. It is my honor to be here today to address this joint meeting of Kerala Federation of OBGYN, the IAP, and the neonatology meet. May I request all those? Yeah, thank you. Now am I audible? Dr. Simi, I'm audible.
Yes, ma'am.
Yes, ma'am. You are audible. It's clear.
You are audible.
So when you come to intrapartum fetal monitoring, it is...
Admin, can you mute the others, please?
Sure, doctor.
Okay. it is a very important thing that we have to monitor both the mother and the baby. Now, I'll just take you through some of the simple, I've not made it very complicated. I've made it as simple as I can. See, initially we monitor the fetus. It was initially done by the Pinard's fetoscope. All of us know that, right? So we would do the low risk auscultation every 30 minutes. And in the second stage, we always monitor them every 5 minutes. In other words, soon after every contraction. Whereas in a higher risk, we actually, in the first stage, we actually monitor with the Pinard's fetoscope every 15 minutes. But again, in the second stage, it's after every contraction or every 5 minutes, okay? It still holds good. It can never be replaced. But how do we normally do that now? What we do is we count the fetal heart for 1 full minute during and after a contraction. So that tells us something equivalent to what happens when we do an electronic fetal monitoring. What happens during a contraction and what happens to the fetal heart after the contraction. So we must record for 1 full minute. Okay. Then, of course, we do the electronic fetal monitoring. Whether we say electronic fetal monitoring or the cardiotocography or the CTG, it all means the same. Okay. When we do that during labor, we call it the cardiotocography. But when we do it in the non-labor stage, we call it the NST. Okay, but it is electronic fetal monitoring. Now, I won't drag you into too much of details about this, but just to tell you what we normally do is the external monitoring. We monitor the fetus from outside rather, the uterus, and this is by the cardiotocography. You saw that picture there. You found there are 2 belts. One belt is actually the cardio, which actually will monitor the fetal heart. And the other monitors the uterine contraction. It is not the true pressure of the uterus that is recorded. It is just a perception. It's just a perception of how the uterus becomes tense. And so it is not the real intrauterine pressure, but that is more than enough for us. Normally, when we do the electronic fetal monitoring in all our labor rooms all over, it is the external monitoring. But then what is internal monitoring? You saw that we have got, the internal device has got a fetal Doppler, which is an electronic node, which is electronic electrode, which is attached to the scalp of the fetus. And then we record the fetal ECG. In other words, we check the RR interval between the, in this particular thing. And what we really record is the fetal ECG. But the problem with this is we have got to have the membranes ruptured. So it is normally done only in a research setting. The second thing is if you're going to do an intrauterine pressure monitoring, again, for this also we require the membranes ruptured. So basically we don't do the internal monitoring. Okay, what we are doing always is external monitoring. Now, critics maintain that there is no significant change in the neonatal morbidity since the introduction of the electronic fetal monitoring. Really, there is not much of a change, but there is some change. Let's see what it is. With regards to neurological injury, the cause of cerebral palsy is less than 10% of the causes are attributable to intrapartum events. So many times there are cases against obstetricians saying when there's a CP that we are at fault. But basically, let me tell you, 90% of the times it's not the obstetrician's problem. It is due to some other cause which causes CP. CTG is meant for identification of hypoxia in the fetus, and it prevents hypoxic brain injury. So we can identify a hypoxic fetus. Let me tell you, the first stage is actually hypoxia. Then after that, the fetus goes in for acidosis. So we can, to a certain extent, even diagnose acidosis in the baby. So it is a very good early evidence of identifying the fetus with this. But the most significant and direct contribution of the electronic fetal monitoring has been in the reduction in the rate of intrapartum stillbirths. With this electronic fetal monitoring, even if we have a hypoxic baby, it is very unlikely that we have a stillborn baby. So that is what really it has been the direct contribution of the electronic fetal monitoring. And always remember, for all of you who are listening, when the electronic fetal monitoring shows us a problem, it is only a screening device. It is not a diagnostic tool. We have to do something more and above that to see whether what is shown on the screen is actually whether the baby is hypoxic or not. So every time so its negative predictive value is better. Look at the second part of my answer there. A reactive NST, that is, I told you an NST is the one that is done before labor. The non-stress test, it is called the CTG when done in labor. So a reactive CTG has got a negative predictive value of 99.9%, meaning that the possibility of a stillbirth occurring within 1 week of a reactive NST is very low. So in a low risk, when you do a CTG, and when you do it in the non-labor state, we call it the NST. If it is normal, we normally say this baby could go through 1 week without much of a problem. But in the event of us having a problem, like she's a hypertensive patient or she's got a fetal growth restriction, then this may not hold for 1 week. We may have to do more frequent monitoring, okay? But look at the top statement, high false positivity rate when fetal heart pattern is suggestive of hypoxia. So 90% of the time it gives us a highly false positive rate when the when the CTG shows us evidence of hypoxia. That is why I said this is only a screening test and that it is not a diagnostic test. Do something more like an artificial rupture of membranes or whatever to see whether the liquor is clear and so on and so forth, to see whether the baby is distressed. Now, in the electronic fetal monitoring, we keep a range of 110 to 160 beats per minute as a normal. We run our CTG, the graph on a scale of 1 centimeter per minute, because if you do like 3 centimeters per minute, etc., we may get a distorted graph. So all of us, most of us rather, we do it as 1 centimeter. That is the scale on which the graph has been adjusted. Now, when a baby is well oxygenated, we say that the autonomic nervous system is pretty well oxygenated. In other words, we say the sympathetic and the parasympathetic is good. In other words, the sympathetic will increase the fetal heart rate, the parasympathetic will decrease the fetal heart rate. So in a well-oxygenated fetus, the constant modulation of these impulses takes place reflected as fluctuations in the basal heart rate. And on the cardiotocograph, this is interpreted as a baseline variability. So because of the pull-push effect of a well-oxygenated autonomic nervous system, we must get a variability between 5 and 25. If the variability is less than 5, that means we are dealing with hypoxia. Do you understand? So that is a very, very important part. So a good variability tells you a well-oxygenated autonomic nervous system. Then we may get a fetal tach. So this could be due to maternal pyrexia, infections, drugs, hyperthyroidism, anemia, premature fetus. It could also be hypoxia or it could be fetal arrhythmias. A fetal brady could be a maternal supine hypotension, or maybe she's dehydrated the mother due to vomiting, connective tissue disorders, drugs like beta blockers. Sometimes we may get a prolonged bradycardia when there is like a cesarean scar giving way or an abruptio or a cord prolapse. In this situation, we get a prolonged brady. Okay, remember when any of these are there, you better watch out. And when do we say a brady? When it is between 80 and 120, with good variability is reassuring. But when it falls below 80 beats per minute, it is not a very reassuring sign. Okay. Now we can also get a sinusoidal pattern. This differs from variability in that it's a regular oscillation in the baseline resembling a sine wave with 3 to 5 cycles per minute. When you see a sinusoidal pattern, it is fetal anemia. And when do you get a fetal anemia? When there is RH isoimmunization, when there's fetal-maternal hemorrhage, when there is a TTTS, or in twins, we get a TTTS, a bleeding vasa previa, in which the fetus is losing blood, or when there's a fetal intracranial bleed. So when you see a sinusoidal pattern on the CTG, it could be a fetal anemia. But you could also get a pseudo-sinusoidal when you're given the patient sedation, like pethidine or epidural. Okay, we can get. So remember that also before you jump saying that there is some problem there, it could be a pseudo-sinusoidal. Then there are 3 basic decelerations. I'm not going to talk too much about it, but decelerations are always thought to occur during labor because it is interpreted in relation to a contraction. And when do you get a contraction? When the patient is in labor. So when it exactly mimics, you look at the picture there, the bottom picture is a contraction, and look at the dip, it actually mimics, it's a mirror image. This is an early deceleration, and this normally occurs due to cord compression. Okay, I mean head compression. So when you get a head compression, and normally when do we get it? When the patient is training in the second stage. So when you get an early decel, nothing much to worry about. It is actually probably she's in the second stage and she's probably pushing. So it is a mirror image of the contraction. But look at the late deceleration. Remember the word after. The fetal heart starts dipping. You saw that? It starts dipping after the onset of contraction. It reaches a nadir after the peak of the contraction and it returns to baseline after the contraction has passed away. You saw that? So when this occurs, that means that it's a uteroplacental insufficiency. Maybe it occurs when there's a hypertension or a preeclampsia, etc. So a late deceleration is bad. And let me tell you one more thing. A late deceleration with poor variability, I told you that pull-push effect, when that is not there on the baseline variability is almost like a straight line, it is bad. It tells you that the baby is not only hypoxic, it is also acidotic. But when you get a variable deceleration, it's the commonest type. If somebody is asked to ask you, it's a commonest type of deceleration is due to cord compression. It's variable in shape, size, timing with reference to the contraction, and it would depend upon whether the vein and the artery in the umbilical cord is compressed. Okay, so these are the basic three decelerations. Early due to head compression, it could be physiological in the second stage. Late when it occurs, when uteroplacental insufficient, variable when it occurs due to cord compression. Now, whenever any of these things are seen, check out, there's something called intrauterine resuscitation. Discontinue the oxytocin. Maybe it is too much of contractions, which is depriving the baby of oxygen. Do a clinical examination and rule out to see whether there's an abruptio, whether the cord is prolapsed, or whether the rupture, whether there's a bleeding due to the scar giving way in labor, etc. Put her in the left lateral position because it may be due to supine hypotension. So check to see whether the maternal hypotension, give her IV fluids, and then check to see whether there's a tachycystole, that is too much of contractions. Then you can give the patient some tocolytic sensi. So there are some intrauterine resuscitative measures which we can try when we see an abnormal CTG. And we always express this CTG findings in this mnemonic, Dr. C bravado. Okay, doctors defining the risk. See whether the mother has got a risk like hypertension, diabetes, whatever. See the contractions. C stands for contractions. BRA stands for baseline variability. Remember, I told you some time back the baseline fetal heart rate, and V stands for the variability, A for the acceleration. See whether there are any decelerations. If there are any decelerations, see whether it's early, late, or variable. And then we make an overall assessment. This would be a good way of assessing. Then we have got this categorization by ACOG. If the category 1 CTG, that means the baseline is between 110, 160, good variability between, good pull-push effect between 5 and 25 baseline variability, no late or variable decelerations. There could be early decelerations, it doesn't matter. And if you see an acceleration, it's very heartwarming, okay? And look at the category 3. Category 3, immediately it's better to take the baby out. It may be absent baseline variability. It could be recurrent late decelerations, recurrent variable decelerations, or it could be a bradycardia, as I told you, or it could be a sinusoidal pattern. Between these two comes category 2. If you get a category 2, which is not category A, which is not category 3, then it is better you re-evaluate the patient. Okay. So the electronic fetal monitoring has come to stay. Its greatest strength is to predict absence of fetal acidemia and acidosis. It's a good screening test. It's not a diagnostic test. Do something more to diagnose a problem. It needs a confirmatory test like a biophysical profile, Doppler, color of the liquor, and so on and so forth. Now, there is something called the fetal scalp blood lactate. Now, this is a very good test. In fact, this can be done. It is better than the pH. The advantage over the pH, which you all check in the neonatal period, you all check the umbilical cord pH, is that smaller amounts of blood is only required for this. And if you find that the fetal pH, the fetal lactate level is less than 5 millimoles per liter, it is good. If it is more, that means the baby is becoming acidotic. So when you find an abnormal CTG, and if you have got access, unfortunately, not all of us have got access to fetal scalp lactate. If you've got access to that, that will definitely tell you that there is acidemia and acidosis of the baby, okay? Then you've got something called the fetal electrocardiography. Now, with hypoxia, you look at the graph there, the T wave and the ST segment. I'll just show you with my cursor. Let me see whether I can take my cursor there. Okay, PQR, this, from here till here. You saw my cursor there, that is the ST segment. So you see whether the fetal, in fetal hypoxia, this ST segment, you saw that segment? You saw that, my cursor, see from this part till this part, okay, this part. If you find that it is elevated, it tells you that the fetus is hypoxic, and with worsening hypoxia, that particular segment will sag. So the ST segment, negative ST segment deflection, it appears, but it's a biphasic thing. It's worsening hypoxia. This is called the STAN, the ST segment analysis. Okay. So if you find it is raised, it's early hypoxia. And if it starts sagging and you find a biphasic pattern, then it tells you that it is a bad hypoxia going in for even acidosis. Then you've got the fetal pulse ox. It is similar to the adult pulse oximetry, but it allows fetal oxygen saturation. Once the membranes are ruptured, you see the baby there, you can keep the pad-like sensor against the fetal face and it is held in place by the uterine wall. So for this also you require ruptured membranes. The lower limit of normal is 30. Okay, if you find less than 30, that means the baby is hypoxic. And let me tell you a few words about meconium. The fetus passes meconium in response to hypoxia. Therefore, meconium signals fetal compromise. Meconium represents a normal GIT maturation also. So when you find a little meconium, it could be a mature GIT of the baby. But meconium passing follows a vagal stimulation due to umbilical cord compression causing increased bowel peristalsis. So that is the problem. When there is hypoxia, there is vagal stimulation and you can get the baby to pass meconium. So when you find a tinge of meconium, nothing to get worried about. But when you find thick meconium, it is bad. Okay, so let me tell you that when you see this, what can you do? Meconium is not seen in acute emergencies. Now, supposing, I remember in the book of Ian Donald, he says, there is no death without defecation. In other words, before a baby dies, always it passes meconium. Okay, so normally we see that with most of our distressed babies, but in certain acute emergencies, like a cord prolapse, it's an acute event, you do not get meconium. An abruptio, that means the placenta has started separating, you do not get meconium. In a scar rupture, you will not get meconium. In any of these conditions, you should remember that you may not get meconium, but the baby could be distressed. So the passage of meconium is not a reason for panic. It alerts the physician and requires close monitoring. We can do a meconium wash, 500 to 800 ml of warm saline, followed by a continuous infusion of 3 ml per minute. This was told to us by Hofmeier. Critics say it does not prevent MAS, okay, the meconium aspiration syndrome, but whatever said and done, it does dilute the meconium and takes the pressure off the cord. Just tell you a few words before I wind up about the partograph. It's a composite graphical record of the progress of labor. It's a single sheet and we call it a tool in which everything is recorded. It has got a lot of disadvantages. It helps us assess labor at a glance, and all the maternal and fetal parameters are noted in that. It has also got disadvantages. I cannot go into that. But it was first introduced by Friedman in 1955. Okay, this was Friedman's partograph. Then later, Philpott and Castle produced 2 lines on this partograph. He said there is a latent phase and an active phase. You saw that. You saw the first part is the latent phase and the second part is the active phase. And in the active phase, you got the alert and the action line. That was what Philpott said in 1972. Then the WHO further modified it and said that there are composite graph and you should produce the alert line, which is the action line, which is 4 centimeters from the alert line. And it was like this. They said, don't have the latent phase because unnecessary interventions are done in the first 8 hours. Then there was a further change. Zhang and colleagues said that after the consortium in safe labor practices, he said the active phase begins not at 3 centimeters, not at 4 centimeters. He said it begins at 5 centimeters. And they also removed the alert line. They said there is no need for the alert line. Then came this phenomenal work, which was done as better outcomes in labor difficulty called the BOLD project. There were 4 important aspects of this project. It was done by the WHO between 2013 and 2018. And this, I'd like to spend a minute on this. This is called the labor care guide of WHO. This is my second last slide. I would like everybody who's listening to me, the partogram has gone out and to be replaced by the WHO labor care guide. Just have a look at this guide. I'll spend 2 minutes on this before I wind up. This is replace the partograph. Okay, you see the first part of this. You will see the name of the person, all the parameters of the person is recorded on that. And remember, I'll just take you with my cursor slowly. Okay, you will have to say when she ruptured the membranes, etc. Then you will also find the parity has got to be written on that. Just a minute. And in that parity, you will have to mention as to when the labor started, etc. Now, the first part, which is called the active phase, all of you just look at that graph. There are 12 bars. They say that there are 12 boxes and it starts from 5 centimeters dilatation. This entire graph starts from 5 centimeters, and you will find that see each block in that, see each block stands for 1 hour. I'll just take my cursor there. Each block stands for 1 hour. There are 12 blocks, and that is the entire active phase, and the entire labor care guide starts from 5 centimeters. And the second part, you see the latter part, the end to my right, that is called the second stage. So you've got 12 hours over here and 3 hours for the second stage. They say that maximum 2 hours for a multi and 3 hours for a primary. Okay. Now, in this first part of my graph, you see this very important column, and that is called the alert column. The alert column. If you see that alert column, oh no, I can't show you that. The alert column is what is the only thing you need actually look into this graph. It is the first part, the first column, and in that you find that the supportive care. We believe in respectful maternity health care. Okay. And in that, if it is marked N, that means has she got a companion? No. If she's got yes, a companion, it is yes. Y. If she has declined a companion, it is D. So if for the alert composition, it is N. If there is an N, you'll have to circle. Everything that comes under the alert is circled. So here it is there. You saw that? It is circled. Then if she's got the pain, if she's got pain relief, if you're given her, if there is no pain relief, it's an alert. If you have got, if she's giving oral fluids, it is no oral fluids, that means it's no, it's an alert. And if you have got a posture, if she's lying supine, it is bad. That's again an alert. If she's on the move, mobile, it is fine. So all that we have to mark in that column, measured every hour for the patient. Okay, every box it has got to be measured. If it falls under any of these alert categories in that supportive care, then you'll have to circle it. I'll show you the next slide, which will show them circled. See, you'll see that it is circled. Then the next parameter is actually the baby. Now, in the baby, we'll actually be looking at whether the baby has got the baseline fetal heart rate. If it is less than 110 and more than 160 is bad. Then look at the decelerations, it's marked L. Only L is alert. Early and variable deceleration are normal. You look at the amniotic fluid. If it is meconium or blood stained, it is bad. Okay. Then you look at the fetal position. If it is a posterior or a transverse position, again, it's an alert. We'll have to mark it as 0. If it's an anterior, it's normal. And then you look at the caput. 1+ and 2+ caput is fine. But if you've got 3+ caput, it is alert. And if you've got molding, 1+ and 2+ molding is okay. But if you've got more than 3+ molding, it's alert. So if you've got any of the alert, you mark it in that particular column against the time, put a circle in that, okay? The third is what the woman is about. You check her maternal pulse, her systolic BP, her diastolic BP, her temperature and urine. If the systolic is more than 120, if the diastolic is more than 90, if her pulse rate is more, or if you've got a urine protein more than 2+ or acetone more than 2+, all that is alert. Anything less than that is not alert. Then you've got the next important thing to see, uterine contractions. See, if the uterine contractions are less than 2, that means she requires something more. If she's got more than 5, it is too much of contractions. Again, it's an alert. Look at the duration. If it is more than, it is a tachysystole, it's an alert. Then you've got all the labor progress in which you see the dilatation. That is, dilatation is marked as X, and the descent of the fetal head is marked as O. And then you look at the medication, look at the next column below that, that's the medication, and then the assessment, and then the plan. So these are 4 important things. That is the supportive care, the baby, the woman, and the labor progress, all to be marked. The rest is what we plan along with our colleagues. This has come to replace the partogram. This has come to replace the partogram. And I think the time has come for all of us to change over to the labor care guide. And with this, this was brought about by the WHO after the BOLD project. And it is said that there was a high incidence of cesarean section, and they realized that the partogram did not reduce the rate of cesarean section. But when you did an overall assessment with the labor care guide, there was a definite decrease in the rate of cesarean sections. So now we have migrated from the conventional partogram to the labor care guide by the WHO. So friends, let us all progress ahead, go ahead, give up on the partograph and go along with the labor care guide. Intrapartum monitoring is a must for a better outcome for both the mother as well as the babe. Thank you so much for your very patient hearing. Thank you.
Thank you, ma'am. It was a wonderful session and very informative talk. You have made it very simple, especially regarding the interpretation of NST. And also, ma'am, have introduced the new WHO labor guide. It's a new thing introduced by the WHO. What we understand is that the NST should be properly interpreted, because if it is not properly interpreted, it may rise in increased cesarean rate. And now, as madam said, partogram have been replaced by the new WHO labor guide. So let's start using the new WHO labor guide. Thank you, ma'am.
Thank you so much. Thank you.
David, sir.
Yeah. So it is a wonderful talk by Serena madam. It's very enlightening. It gives the neonatologists and pediatricians a deep insight into the obstetric part, which is in fact very useful for the management of the neonate as well. So thank you, madam, for that brilliant talk. And now over to is the Dr. Lalitambika madam has joined?
Not yet, sir. Couldn't contact also, sir.
Okay, then we'll go to next topic in the agenda, implications of ART by Dr. Raghavendra Prasad, Sunrise Hospital, Kanyanad. Dr. Raghavendra Prasad.
Yes, sir.
Welcome, sir. Please.
Good evening, everybody. Thank you, NNF, AFOG, and IAF Perinatology Committee for giving me the opportunity. With the advent of IVF and the boom of IVF babies, it is necessary now to know the long-term implications of ART. So I'll be sharing my screen now.
Yeah, please.
Yeah, is it visible?
Yes, very much, sir.
Yes.
Yeah.
Yes.
Okay. Now, the treatment of infertility for decades have seen the development of revolutionary new modalities of like ART or IVF, as you say, was first achieved in 1978 with the birth of Louis Brown. After that, you have methodologies like ICSI, where intracytoplasmic sperm injections, and also PGDs, where pre-implantation genetic diagnosis also emerged. So the understanding of these long-term impacts of these treatments, which have been linked with several potential complications affecting the mother and child, is always a constant challenge. So the treatment of infertility for decades has seen as the development of revolutionary new modes of ART. But there is definitely lack of literature and no adequate RCTs of sufficient power available to assess the efficacy and safety of various forms of treatment modalities. So there is a need for assessment of the safety of ART, especially long-term safety. So the definition of success of IVF has started shifting from pregnancy rates per cycle to healthy singleton child per started course of treatment. To achieve this aim, the first change had to be in what medications we use, with the pain of with the aim of causing less pain or less stress, reducing the cost, reducing the complications, and still achieving good oocyte, embryo, and also good implantation rates. So further, progression of technology aiming at minimizing complication rate, but yet maintaining optimal pregnancy implantation rates. So what are the factors which commonly affects one? When you look at the mother, you can think of the age of the mother at the time of conception and birth, and often the firstborn child. From the father's side, you have the paternal age of conception. The fetal factors can be embryo quality, less healthy in utero environment, the number of fetuses, and also the maturity part when the baby is delivered. Childhood factors can be the perinatal risk, such as prematurity, congenital anomalies, the social background of the parents, and also psychodynamic factors. So the long-term outcomes in children, which were included in various publications, were 1. Malformations, 2. Chromosomal abnormalities, childhood tumors, growth disturbances, neurological developmental disturbances, autism spectrum disorders, and also the transmission of subfertility to the male offspring. So when you look at congenital birth defects, you have NTDs, esophageal atresia, omphalocele, hypospadiasis, and cardiac defects, which are commonly seen in, you can say, IVF babies. The incidence was 8%, which was a twofold increased risk. Probably the reason which they suggested was because of the exposure of the embryo to the mechanical, thermal, and chemical alterations during ICSI and cryopreservation. So children born after ART have poorer outcomes than spontaneously conceived children, mainly because of the high rate of multiple births and also the associated perinatal mortality, preterm birth, and low birth weight associated with this. The study from Lancaster in the year 1980 was one of the first to report that babies born with IVF had high risk of NTDs and also cardiac defects. It suggests that approximately 40% of the defects are due to single mutant genes and major chromosomal abnormalities, and about 5% are due to environmental factors such as infections and toxins, probably drugs, alcohol, etc. And another 20% is due to the combined effect of environmental and genetic factors. But 60% or more, the cause of malformation is still unknown. Other reasons which they have considered was that with ovarian stimulation, there is a possibility of change in the follicle milieu and oocyte structure. Sperm preparations, which theoretically increase the exposure to substances that might change their natural function, and also the manipulation of the gametes, which may lead to an increase in these problems. So congenital anomalies with ART, as I told you, can be anencephaly, spina bifida, cardiovascular defects. You have orofacial clefts and also alimentary tract atresia. Anencephaly and hydrocephaly have been again seen in association with higher rates of multiple births, which probably and the general increased risk of anomalies with ART could be due to parental characteristics also. A fourfold increase in incidence of heart malformations, especially septal defects, was found by a study conducted by Covier et al. The reproductive ability with different maternal hormones may be inversely related to the risk of VSD. An association of ovarian stimulation and the birth of infants with orofacial clefts and with neural tube defects has been described. An increased prevalence of only genital organ malformations has been associated with singletons born of infertile couples, which may be used because of the use of ovulation induction drugs. It's like you have a higher incidence of hypospadiasis when clomiphene citrate was used as the ovulatory inducing agent. So ART was associated with 1.5 times increased risk when compared with spontaneously conceived pregnancies. There were no differences among ICSI using ejaculated testicular and epididymal sperm. Also, the ICSI fresh transfer embryo has a greater risk than frozen transfers. Although vast majority of births resulting from ART were free of birth defects, treatment with the use of ART is still associated with a higher risk of birth defects compared to the general population. The risk may be because of the procedure itself. As I told you, the manhandling, or you can say the handling of the sperm or the oocyte, injection of foreign or sperm-associated exogenous DNA, errors in selection of the injection site, and physical or biochemical disturbance of the ooplasm or of the meiotic spindle. The procedure-independent risk can be the micro-injection of a sperm carrying a chromosomal anomaly, the transmission of a genetic defect that is often the origin of the male factor infertility, male gamete structural defects, anomalies of sperm activating factors, and potential for incorporating sperm mitochondrial DNA, and also you have oocyte related gamete anomalies. So although most children conceived by ICSI are healthy and develop normally, there is an increased risk of mild delay in development at 1 year of age when compared with children who conceive by routine IVF or by natural conception. So when you have a Y chromosome microdeletion, which is observed in 3 to 15% of men with severe oligospermia, using of this sperm can again during ICSI can transmit the same genetic condition to the male offspring. More boys conceived by ICSI were found to have undescended testes and required genital surgery. The other common factor or the defect which is there is the imprinting disorders. That is, loss of epigenetic control may expose a few hidden genetic variations. It can occur in abnormal environment such as in vitro. So all types of corrections have been tried by companies by using the media to make it as physiological as possible. But it is very rare. It occurs 1 in 14,500, something like Beckwith-Whitman syndrome. So superovulation rather than ICSI may further increase the risk of conceiving a child with an imprinting defect. As I told you as previously, it is very rare. It is 1 in 12 to 14,000 births. And the common disorders which we see are Prader-Willi syndrome, Angelman, and Beckett-Whitman syndrome. So as I think this, you guys will know better than me. Prader-Willi is a genetic disorder caused by a loss of function of specific genes on chromosome 15. Angelman is a complex genetic disorder that primarily affects the nervous system with delayed development, intellectual disability, speech impairment, and problems with movement and balance. Beckwith-Whitman is the most common overgrowth and cancer predisposition disorder. And you have a wide spectrum of symptoms and physical findings, which can change from person to person. What is a neurological or autistic risk? Again, ART is an independent risk factor for autism spectrum disorder. When you look at the perinatal risk, it's mainly because of preterm birth. So one of the commonest factors for preterm birth is multiple gestation, and it is around 23% increase in the relative risk of preterm births in IVF twins, again compared to normal twins. So similarly, in singletons, there is an estimated 2-fold increased risk of preterm births following IVF. Even term births around 37-38 weeks are associated with respiratory problems in comparison with late term births. Low birth weight, again, singleton IVF pregnancies still demonstrate an increased risk of low birth weight when compared with naturally conceived singletons. So women receiving IVF, again, as we know, have a high increased risk of twins and also of further higher order pregnancies. So compared with singletons conceived spontaneously, ART infants will have around a 2-fold increase in risk of perinatal mortality, low birth weight, and preterm birth, and also a 50% increase in SGF, small for gestation age, and 30 to 35% increase in birth defects. Older maternity has a higher risk of placental insufficiency, hence leading to poorer fetal growth and also again lower birth weight. So suggested perinatal mortality is about 40% lower in pregnancies after assisted compared with natural in twin conception. So overall, the review indicates that there is not much difference in the outcome of ART twins compared with normal twins, but increased rates of maternal hypertension, preeclampsia, and spontaneous, including abortions, and also the need for cesarean delivery. And IVF children appear to survive the neonatal period worse than the general population group. Perinatal risk associated with ART and ovulation inductions are higher again in higher order pregnancies. However, it is unclear to what extent these associations might be related to the cause of infertility. So before initiation of ART, couples should be thoroughly explained, have a proper medical checkup, check for all disorders, thyroid, hypertension, and diabetes, etc. And also counseling is very important. We need to counsel them that when you have a higher order pregnancy, there is a possibility of preterm birth, increased neonatal care, and such also the increased cost. So some studies have also observed that there is an increased risk of neurological problems with ART compared with spontaneously conceived children, especially CP. But this can be explained because of high frequency of twins born at a lower birth weight and at an earlier gestational age. A 40-fold increased risk of CP in a twin surviving the death of the other twin, mainly in the third trimester, has been observed. And it is known that monozygotic twinning is increased after IVF. And one of the commonest reasons is assisted hatching of the human blastocyst in its various forms is one of the reasons caused for this monozygotic twinning. So monozygotic twinning is associated with increased perinatal morbidity and mortality. In ART, monozygotic twinning is a common condition, while it is rare in natural conception. And it has been associated with increased risk of growth abnormalities and TTTS. Monozygotic twinning remains speculative. Given the, again, possible complications, we need to go in for proper counseling. And when you look at the mother, the advanced maternal age is again associated with increased risk of pregnancy loss, live born aneuploidy, whereas advanced paternal age is associated with fresh Mendelian mutations. So higher rate of de novo chromosomal abnormalities have been observed in ICSI offspring, relating mainly to higher number of chromosomal anomalies and partly to a higher number of autosomal structural anomalies. So children, I would like to impress again, children born with ART are healthy and they develop similarly to children born after spontaneous conception. Regarding general health, growth, mental and psychomotor development, IVF children do not differ from spontaneously conceived children, but lower birth weight and prematurity may contribute to some of the problems. What is the oncogenic risk which is there? So there is very limited data on the use of oncogenic risk on the mother with the use of such medications, because the use of infertility drugs does not appear to increase the risk. There is no evidence of transmission of Prions disease by any presently used gonadotrophic. And regarding gynecological cancer, carcinoma in women undergoing ovulation induction, it is not very easy to determine because there are many confounding factors like infertility, the age of the patient, the drugs used alone or in combination. When you look at the children born through IVF, there is a higher possibility of leukemia, lymphoma, neuroblastoma, retinoblastoma, and hepatoblastoma. But ART conceived children do not have an increased cancer risk after a median follow-up of 20 years, as per one study. However, more research is required evaluating the children born after ICSI with fresh embryos or with cryopreserved embryos. Whatever it is, ovulation induction again does not increase the risk of gynecological cancer, but the risk of ovarian cancer also is not increased, even though when you have borderline tumors, there is a risk of borderline ovarian tumors. Again, further studies and further evidence is required. And there is no strong, again, link between the use of fertility drugs. But when you have borderline tumors, there is a risk of it progressing to a next level. So collective data regarding the risk of developing cancer from the use of fertility medications are reassuring. There is no association found between fertility drugs and risk of ovarian cancer, but long-term fertility drug use and the effect of fertility treatment on women who have already genetic predisposition like BRCA1 or 2 gene mutation is usually limited. With IVF and breast cancer, there is no significant association between IVF and breast cancer in the infertility treated group. So what are the recommendations for on ovarian stimulation and ovulation induction? Again, no direct association was found among IVF treatment and invasive cancer. No association was found in short to medium among IVF and adverse outcome in children born from ovulation induction, but long-term health outcomes in women and children is still awaited. So the use of ovulation induction should be limited to the lowest effective dose and duration as possible. The use of the concept of using medicines every month for ovulation induction as much as possible till the patient becomes pregnant should be avoided as much as possible. We stick to protocol as much as we can. We have to inform the women about the absolute risk of long-term adverse outcomes of IVF treatment, also ICSI, and also that there might be a small possibility of ovarian malignancy, especially if she's already had a history of borderline ovarian tumors. We need more studies to examine the effects of IVF. So to conclude, I would say that children conceived by ART are more likely to have congenital anomalies compared to children conceived spontaneously. Most of the children are normal, and there is no additional risk of major birth defects in children conceived by ICSI compared with the children conceived by other IVF methods, although hypospadiasis is a little bit more common with ICSI. ART is also associated with a higher risk of imprinting disorders, especially Angelman and Beckett-Widman, although it is very rare. Twins born after infertility treatment have not shown higher prevalence of congenital malformations in comparison to twins born of the regular couples without people who have had treatment. But there is an increased incidence of monozygotic twinning. Along with that, you have the associated risks also. And infertility itself is likely to be an important factor in congenital anomalies, like where you have a genetic abnormality of the male, which can be transmitted to the offspring also. Thank you.
Thank you, Dr. Raghavendra Prasad, for that enlightening and very informative talk, the implications of ART, because it's a very relevant topic in the present day. Nowadays, in our daily day-to-day practice, we are seeing a lot of IVF cases and more number of preterm births and hence more number of NICU admissions also. Dr. Devi? Sir, can you unmute?
Elizabeth is yet to join already. Madam, please. Your talk on fetal surveillance Doppler.
Very good evening, all of you. At the outset, let me thank the organizers for inviting me to be a part of this program. So next 20 minutes, I will be talking to you on the use of Doppler in antenatal fetal surveillance. Shall I share my screen?
Yes, madam.
antepartum surveillance is one of the most important aspects of antenatal care. Beginning with simple auscultation of the fetal heart and counting fetal movement, we have advanced a lot in monitoring the fetus with the use of grayscale ultrasound and Doppler ultrasound, NST, and such advanced methods. But the question comes, which is the best? Biophysical profile and NST become abnormal only when there is severe hypoxia and or acidosis. Whereas Doppler study involving various fetal vessels detect fetal compromise at a much earlier stage. Though that statement is there, they are complementary to each other. When Dopplers are abnormal in a very preterm fetus, we have to depend on BPP and NST to prolong pregnancy to the maximum extent to avoid or to minimize the risk of prematurity. And the role of Doppler in antenatal surveillance starts in the first trimester. So at the end of the first trimester, NT scan is done. At the same time, we can do uterine artery Dopplers so that it can give you a clue to predict early onset IUGR as well as early onset preeclampsia. And we can start aspirin prophylaxis to prevent these complications. At the same time, you can also screen for trisomy by Doppler by doing the Doppler of the ductus venosus and the tricuspid valve. These two will give you a clue to risk for trisomy. Coming to late pregnancy, second and third trimesters, Doppler study has a very important role in early detection of placental insufficiency in high-risk pregnancies, but recent studies show that even in low-risk pregnancies, Dopplers will help to reduce perinatal mortality. I will explain it later. And so it is useful in diagnosis of FGR, that is to differentiate between small 4 data and FGR, timely decision-making in FGR, that is when to terminate the pregnancy between intrauterine, without getting intrauterine damage to the fetus, intrauterine death, at the same time minimizing the risk of prematurity. And the type of Doppler abnormality before birth will give important information to the neonatologist regarding probable neonatal complications the baby is prone to after birth. So SGA means traditionally we are defining SGA as weight less than 10 centile. All SGA babies require Doppler evaluation. If Doppler is found to be normal, it is a constitutionally small and healthy fetus, very unlikely to have metabolic derangement and complications in neonatal period. But if the Doppler is abnormal, then we make a diagnosis of pathologically growth restricted baby. That is the baby which has failed to achieve the genetic growth potential. And some of the constitutionally small healthy fetus during follow-up may develop Doppler abnormalities, and they also are categorized as pathologically growth restricted. And this pathologically growth restricted group includes two different, phenotypically different entities: early onset FGR, that is onset of FGR before 32 weeks, and late onset FGR, where the FGR occurs after 34 weeks of gestation. Yet another important point we have to remember when monitoring fetus is that every fetus has its own growth potential and its own growth rate. So rather than looking at the 10 centile, taking the cutoff as 10 centile, we have to compare the growth of the baby with its own growth pattern. If the baby who started his growth at 70th centile, on follow-up, if it falls to some 20 or 25th centile, even if it is above 10 centile, this baby should have Doppler evaluation, because otherwise it will develop complications. Whereas a baby who started his growth at the lower profile continues in the same profile, this baby is not at risk of complications of growth restriction. So taking the cutoff of 10 centile gives us a false sense of security. Unexpected perinatal mortality can occur even if the weight is above the 10 centile, especially with late onset IUGR. So there was a study by Gardosi and others who studied the case of intrauterine death, and he found that antenatally detected IUGR contributed to 9.7 per thousand death, whereas antenatally undetected IUGR contributed to 19.8 per thousand birth. That means if we take the cutoff as 10 centile, many of the growth restricted babies may be missed. You have to do Doppler study for babies who do not follow the normal growth pattern. So you have to look at the growth chart rather than looking at the centile value of the weight of the baby in the last term. So the indications of Doppler study to sum up, one is weight less than 10 centile, everybody follows that, but also fetuses with abnormal growth rate, you should pick up by seeing the growth chart and subject them to Doppler studies. And what are the sequence of events in a Doppler study? It is mirror image of the fetal oxygenation status. So Doppler will tell you whether the baby has normal oxygenation status, hypoxemia, hypoxia, acidosis, cardiac dysfunction, or even cardiac failure. And when do you do? Already first trimester I have told. Then later on, when the weight is less than 10 centile or significant lag in growth, you can interrogate umbilical arteries, middle cerebral artery, and ductus venosus. Each has got its own significance in making a decision regarding termination of pregnancy or continuation to avoid iatrogenic prematurity. And Doppler signals are quantified by pulsatility index and resistance index. In obstetrics, usually we follow pulsatility index. It is simple to remember, when the diastolic flow is good, pulsatility index will be low. When the diastolic flow is less, pulsatility index will be high. If you remember the simple point, it will be easy to interpret the Doppler values. Another point is that rather than giving the absolute value, the radiologist or whoever is doing the scan should give the centile values of that particular patient. Then only we will be able to compare with the normal centile. For example, if the umbilical artery pulsatility index is 98 centile, immediately we know it is abnormal because 95th is the cutoff. Similarly, middle cerebral artery, 5th centile is the cutoff. So if it is less than 5th centile, we know it is abnormal. So if you get the absolute value, it will be difficult for the person evaluating the Doppler report to interpret. Now, one word about fetal circulation. Placental resistance is the most important factor that determines the fetal circulation. The umbilical arteries enter the placenta, and because of the very low resistance, there is no impedance to flow, and there is continuous flow in the umbilical artery even during diastole. And this blood gets oxygenated, supplied with nutrients in the placenta, and returns to the baby via the umbilical vein. And from the umbilical vein, only 18 to 25% of the blood enters the right atrium through the ductus venosus. The rest is directly shunted to the liver. That is the normal physiology. But when baby becomes hypoxic, changes occurs in normal physiology of this distribution of blood between heart and liver, and that leads to important Doppler changes. So this is just to show the normal uterine artery flow. There is good diastolic flow in the uterine artery, and when there is low diastolic flow and persistence of diastolic notching beyond 24 weeks, that means this pregnancy is prone for development of hypertension or intrauterine growth restriction. And also, if you calculate the pulsatility index, it should be less than 95th centile. So these 2 points will give you a clue whether the baby is going to develop a complication and whether you need to monitor the baby with Doppler. This is the normal umbilical artery waveform. As I told earlier, this is the systolic flow and this is the diastolic flow. There is good forward flow even during diastole. This is possible because of very low resistance in the placenta. This can happen only if the trophoblastic invasion is normal. If there is impaired trophoblastic invasion, placental resistance will be high and diastolic flow will be reduced. Next vessel is the middle cerebral artery. Normally, middle cerebral artery has, or cerebral circulation is a high resistance flow pattern. But when the baby is hypoxic or hypoxemic, there will be compensatory mechanism resulting in dilatation of the middle cerebral artery, so-called brain sparing. And pulsatility index in the middle cerebral artery decreases. So this is the normal pattern. When there is minimal vasodilatation, there is slight increase in diastolic flow. Marked vasodilatation, there is marked increase in diastolic flow in the middle cerebral artery, thereby reducing the pulsatility index of the middle cerebral artery, which is pathological. Third vessel that is important in decision making is ductus venosus. Normally, I told you nutrient-rich blood from the placenta, only 18 to 25% will be going directly to the right atrium, the rest will be going to the liver. But when there is hypoxemia and hypoxia, there will be redistribution, and the magnitude of umbilical venous flow also will decrease because of the placental resistance. Less blood will be entering placenta, less blood will be going out of the placenta. In response to these changes, the change in proportion of the umbilical venous blood diverted through ductus venosus towards the fetal heart increases. At the same time, middle cerebral vasodilatation also occurs. So flow velocity in the ductus venosus increases and the cerebral pulsatility index of the cerebral vessels also decreases. So this is the normal pattern of the ductus venosus. This is the peak during ventricular contraction. This is ventricular diastole and this is atrial contraction. This is the most important part of it because though ductus venosus is directly entering the right atrium, even during right atrial contraction, ductus venosus flow is not obstructed. It is continuously draining into the right atrium. This is because of the good compliance of the right atrium. But when the baby is hypoxic and when it becomes acidotic, compliance of the right atrium decreases, myocardial dysfunction occurs, and flow during atrial contraction becomes absent or it gets reversed. So, to sum up the changes, proportion of blood from ductus venosus to liver increase, to heart decrease, and to heart increase. Preferential cardiac and cerebral blood flow results to reduce flow to liver and gut. And the consequence of this is nutrients are not supplied to the liver, so liver glycogen stores are depleted, no more glycogen synthesis, no more fat synthesis, so liver size decreases and the subcutaneous fat decreases, which actually manifests as growth retardation. So all these changes are going on. Right ventricular afterload increases, myocardial impairment occurs. Yet another important factor is cerebroplacental ratio. So middle cerebral artery PI to umbilical artery PI. Normally, middle cerebral artery has a low PI and high PI, and umbilical artery has got a low PI. That means diastolic flow in middle cerebral artery is less and diastolic flow in umbilical artery is good. So ratio should be more than 1. But when there is cerebral vasodilatation, this ratio reverses. And always you have to look at the independent pulsatility index value, not only the ratio, because sometimes there could be isolated middle cerebral artery vasodilatation and change in PA of the MCA alone. So MCA PA less than 5% is always risky to the fetus, even if the umbilical artery pulsatility index is normal. That is yet another factor we have to remember. So this shows the relationship between the umbilical artery flow and the placental disease. When about 30% of the placenta is damaged, cardiac function is still normal. There is some amount of forward flow during diastole. But up to 70% of the placental damage, there is absent end diastolic flow. And when the placental vasculature is damaged more than 70%, cardiac pump becomes abnormal and there is reverse end diastolic flow. So all these have got implications in neonatal management because the Doppler abnormality will tell you, the pediatrician, what type of complication the baby can have. A baby with the reverse end diastolic flow will be definitely acidotic. So all the complications of severe hypoxia and acidosis can be expected in this baby. And this is the ductus venosus abnormality. So ductus venosus, gradually the atrial forward flow during atrial contraction decrease. It becomes absent, then it becomes reverse, and finally all the flow during all 3 waveforms become abnormal. So again, this is the stage when baby has acidosis, and this is the stage when baby is severely hypoxic but still has not gone into acidosis. And how does this correlate with our biophysical profile and NST? Early stages of Doppler abnormality, biophysical profile and NST will be normal, and they will become abnormal. That is absent fetal movement, absent breathing movement, only when the baby becomes acidotic. That is pH between 7.1 and 7. When there is further deterioration of the pH, late deceleration of the fetal heart develops. So NST deceleration, spontaneous deceleration is a very late sign, and that denotes the cardiac failure, and that just precedes fetal death. So if the baby is showing spontaneous deceleration, baby is severely acidotic, and intrauterine continuation is definitely hazardous. The baby may die in utero within a short period. So this also already have explained, because of the redistribution of blood, less blood is going to the liver, the baby will manifest growth delay. So the another point we have to remember is, though we are able to identify the cardiovascular changes and behavioral manifestations of the baby, that is lack of movement, lack of breathing movement, etc., by grayscale ultrasound and Doppler, other changes that occurring in the baby parallel to this, that is metabolic, endocrine, and hematologic changes, we are not able to identify antenatally. So we have to assume that when baby has Doppler abnormalities, baby also will be having metabolic, endocrine, and hematologic and immune abnormalities. So the metabolic compromise will be intrauterine hypoglycemia, aminoacidemia, hypercapnia, hypertriglyceridemia, and hyperlacticemia. So baby will have all sorts of metabolic abnormalities when there is Doppler. And the endocrine manifestations include, because of hypoglycemia and hypoaminoacidemia, there is downregulation of insulin and insulin-like growth factors 1 and 2, which are the principal endocrine regulators of longitudinal growth. So longitudinal growth of the baby also may be affected because of the endocrine effect. And this can reflect in the postnatal period also. It will affect the bone mineralization and potential for postnatal catch-up growth and linear growth of the baby. And the fetal hematologic response to hypoxia is erythropoietin release, resulting in polycythemia. But initially, this occurs as a compensatory mechanism, but increased viscosity of blood further impairs the placental circulation, and this leads to more damage to the baby than benefit to the baby. And finally, in the neonatal period, such babies will have severe hyperbilirubinemia. Yet another problem of babies with these Doppler abnormalities are immune dysfunction at the cellular and humoral level. We know that babies with growth restriction, they are at higher risk of infection. It is because of this cellular and humoral level immunosuppression because of the hypoxic damage to the baby. And there are studies which show that abnormal Doppler studies in utero is associated with postnatal circulatory disturbances like reduction in systemic blood flow, as evidenced by functional echo of the newborn. And reduction in systemic blood flow is associated with more perinatal morbidity and mortality and increased complications like intraventricular hemorrhage. So in utero Doppler abnormalities, they do not stop it by delivery. Complications do not stop by delivery. These babies are more prone to have complications in the neonatal period. Yet another use of Doppler is to stage IUGR by various Doppler findings, which enables us to have an objective assessment, and a protocol-based management can be instituted. So stage 1 IUGR is mostly seen in late onset. Here, either there is MCA PI less than 5th centile or cerebroplacental ratio less than 5th centile. This occurs usually after 34 weeks. So we have baby sufficiently mature, closely monitor and deliver by 34 to 37 weeks. And stage 2 IUGR is severe placental resistance. Ductus venosus will be still normal. There is absent diastolic flow in the umbilical artery. And stage 3 will be reversal of flow, and still ductus venosus pattern is normal, but flow velocity is poor. And stage 4 will be reversal of A wave in ductus venosus, and this is the time when CTG will start showing abnormalities. So now we understand the relation. Early stages of Doppler abnormality, CTG and BPP will be normal. And this correlation, this is important, especially when the baby is preterm. We don't want to deliver a too preterm a baby. Even when the Doppler is abnormal, we can do CTG and BPP very frequently, even daily or even twice daily, and prolong intrauterine existence as long as possible. And so depending upon the stage, you can continue the pregnancy. So this is very objective. It's not subjective. That is the advantage of utilizing this classification. If it is stage 1, you can continue up to 34 to 37. Stage 2, 32 to 34. Stage 3, 28 to 32. And stage 4, delivery should be obtained between 26 to 28 weeks, because the risk of intrauterine death will be more if you continue the pregnancy. Now, though it's a very useful tool, it has got its own limitations because it is operator dependent. Unless you have good training and expertise in reporting, it's not going to be useful. It may be more harmful. It is a little time consuming because you have to spend some time to get the accurate flow pattern, accurate installation should be accurate and pattern should be accurate. And the time scale over which placenta insufficiency and fetal compensatory changes develop varies. And it depends on not only on the fetus, but also on underlying maternal complications like hypertension, diabetes, etc. And depending upon the gestational age also. So same management protocol cannot be applied blindly to all babies with same Doppler findings. You will have to individualize management. And normal Doppler findings do provide some reassurance and reduce the need for hospitalization and additional fetal monitoring. That's a very important advantage because unnecessarily we don't have to terminate the pregnancy when the baby is still preterm. And predictive accuracy of CPR decreases after 34 weeks. This is an important point obstetricians have to remember. In after 34 weeks, sometimes there may be normal umbilical artery blood flow, but isolated brain sparing as the only sign of placental insufficiency. These fetuses are also at risk of adverse outcomes. So we have to independently look at umbilical artery as well as the middle cerebral artery. And to sum up, absent end diastolic flow, reverse end diastolic flow of the fetal umbilical arteries are associated with poor neonatal outcome because the baby is already severely hypoxic and acidic. And premature delivery, they are at high risk for premature delivery, high risk of NICU admission, need for respiratory support after delivery, stillbirth, and postnatal neurodevelopmental impairment. Not only this, they are also prone for long-term complications in adult life like obesity, cardiovascular morbidity, and hypertension. MC and ductus venosus Doppler abnormalities help to identify cardiovascular status of the fetus. That is very important, whether the cardiac function is normal, and help us in decision-making of termination. Doppler studies help the obstetrician to decide on optimal timing of termination. We can also avoid, not only deciding on termination, also avoid iatrogenic premature death. Moreover, it gives clue to the neonatologist to anticipate complications in the newborn and adopt appropriate management protocol for the fetus born with Doppler abnormalities. Thank you very much for the patient hearing.
So we had three brilliant talks from experts in the field. Okay. Lalitambika Madam, thank you very much for your talk. Dr. Serena Gilwas for the talk on intrapartum monitoring, and Dr. Raghavendra Prasad for implications of ART. Any questions? We can have a brief discussion before we go to the next part of the program. Should you have any questions, kindly unmute and ask.
Sarina madam. Sarina madam.
Dr. Simi, would you like to add something?
No, sir.
I think the talks were so clear that nobody has any doubts on the topics discussed here. Even in the chat box, I don't find any questions or queries. From the faculty, anything else you would like to add? Any take-home messages or anything for the audience, for the participants? In a nutshell.
Ajit, sir.
Neonatologists comments on use of Doppler, whether they depend on Doppler findings, whether they evaluate, when they evaluate the newborn, do they have any opinion on that? What is their opinion? A baby with abnormal ductus venosus, baby with absent and diastolic flow, all these Either management, how do they modify?
Dr. Manoj?
From the neonatologist, I think we would like to know it because nowadays we are doing lot of cesarean section in the preterm cesarean section. Is it easily benefiting the babies actually? Just because of the Doppler reversal of flow, all these things we are doing it. 30 weeks, 32 weeks, we are doing cesarean section. Is it benefiting the baby actually? What is the long-term outcome?
Of course, the prematurity is a problem.
Actually, from a neonatology point of view, if we get an abnormal Doppler and this, if it's a really abnormal Doppler, what we are worried in short-term basis is we will be more cautious in grading up feeds, especially if the baby is IUGA plus Doppler abnormalities. So the grading up of feeds will be very slow. Otherwise, the current trend is to go faster on grading up of feeds. That's what practically what matters.
Can I make a comment?
Yes.
Sure, sir.
Okay. Very good presentation by Dr. Lilithambika. See, when you are having such a preterm babies, especially around 28 weeks, and you are having ductus venosus change, you have to look at the neonatology care available to your center. Because if you do it is only by cesarean section around 28 weeks if you want to get this abnormal baby, or because of the abnormal Doppler findings, termination by cesarean section. And if you do a cesarean at around 28 weeks, average survival, intact survival may be 50%. So you have to be counseling the patient and also look at the facilities available to you in your center, neonatology care especially. So having found out that it is such a sort of abnormality, the continuation of pregnancy will result in intrauterine death. For salvaging that baby, it all depends upon the each day around that period will count a lot. It will improve the intrauterine life if you can prolong. That is why you are going from umbilical artery to middle cerebral artery to ductus venosus. That is the last. If that is also showing at a very early onset growth restriction, or it is only termination. And what is the chance to survival as per our situation or per the center where you are working? If you think that some other centers are doing very good work, please transfer the patient there and try to get this baby. It is salvageable baby as per that, maybe 50-60%, but you may have to do a cesarean. So that has to be well understood by the couple. But if it is otherwise, beyond 34, below 34 weeks, of course, 32 weeks, now you have got the antenatal max self, which is neuroprotective. It is found to be very useful. If we have to terminate around 32 weeks or so, and anticipate that give max self, which is the same as the eclampsia regime, and give that 24 hours or at least 12 hours, 1 gram per hour. That is a really neuroprotective, and also the steroids for lung maturity. And these two measures, and at the correct time, termination by the correct route. So below 34 weeks, these patients may not stand with this abnormality, induction of labor and delivery. But beyond 34 weeks, there is a place for induction and achieving vaginal delivery if it is not of that extreme level of ductus venosus change. If it is on the umbilical artery, say absent diastolic flow and all, if you are going to terminate by 34-35 weeks, that's a very good chance of getting the baby by vaginal delivery also. So all depends on the care available, the gestational period, and then the severity of the Doppler change. So Doppler is definitely helping us to make a decision rather than allowing a intrauterine death. So avoid a intrauterine death. At the same time, by interfering, it should not be shifted to a neonatal death. The perinatal mortality is the same, whether it is intrauterine death or neonatal death, it is the perinatal loss. So we have to avoid all those situations. A very nice balance has to go. So Dr. Lilithambika has given a very nice description of the Doppler studies. We have to know what is the interpretation of the Doppler study and make a correct decision. and we should know when to terminate in such fetal growth restriction now. So we cannot, because this is the late onset FGR is one of the reasons for the intrapartum deaths, an important cause. So it is important, as Dr. Lilidambi has pointed out, even the SGA baby has to be monitored. Otherwise, it may not show much changes, but they should not go beyond date. So termination may be by 38 to 39 weeks, even in the SGA group of patients. Otherwise, you are going to lose that babies also. They may be small for date, but they are not having much of a placental insufficiency sort of a situation. But they may not stand beyond term. So that is also the correct termination, the correct time is going to save that baby. So it is all important, all of us, to understand the Doppler changes and monitoring. And Dr. Serena was giving a very good account of the latest WHO labor care. The two important things that you have to remember, it is not only the scientific thing, it is the respectful maternity care. They are stressing onto that. There should be a companion of choice, and there should be pain relief. These are the two important components of this bundle. And we were not much concerned about it earlier on. Now that is not the case. The patient has got her choice, and you have to respect her wishes. So that is what is being very much stressed by the WHO labor care bundle. So thank you, Dr. Serena, for that wonderful presentation again. So thank you all, and I hope we all understood from you what all things are. Dr. Ajit Devendra Prasad, though frightened us with the complications of IVF, but he has also mentioned that very many babies are born normally. That is the importance. Otherwise, they may not have got a baby. So you are giving a couple a chance to have a child, which is most often it is normal babies. But all the abnormalities are there. That's where even the pre-implantation genetic testing is also important to avoid the abnormal babies being grown by this method. So thank you all for that wonderful knowledge that you have given to all of us. Thank you.
Just one clarification. Can you hear me? Hello?
Yeah.
To Sarina Madam, Madam said in the new labor care guide, the duration of active stage after 5 centimeter dilatation, they have said as 12 hours. So is that
that is not what she said. That is not what she said. It is said that it is the importance is that there's no time limit as we were all afraid of beyond a certain stage. So she said that a primate can have 3 hours of second stage. That is the latest thing. Before interfering, if things are going on, you can allow time for the development. In the second stage of first stage of labor, up to 5 centimeter is taken as the latent phase, and that is the change. From there on, you can give even up to 12 hours is what is in the chart, but they will deliver within 2 or 3 hours in a multi.
Yes, that's what exactly I wanted to know.
They will deliver.
The maximum time that you can give is 12 hours.
That is going on. I had a talk with that Sangwe of the Japaigo. I said, I think probably these people are telling us to wait so much because that is the baby may remain normal. You can allow time. That is the only meaning. We are not going to wait for 12 hours, or it is not necessary to have that waiting after 5 centimeter dilatation in a multi. She may deliver in another 2 hours. So that is the practical thing. So also what they're selling, if everything is okay, in a primate gives time for the progression, rotation, and delivery of a normal responding baby. That's all. We will not wait in the given situation. That is what it is. So their stress is on to the maternal support mainly, and nutrition, and the position of labor, of convenience to the patient. So these are all, that's a big thing. The WHO labor care bundle is, I think it's all available online. We should all read it. And the stress is onto the respectful maternity care. They repeatedly say that. You have to accept what is the demand of the woman. You cannot have the behavior of some of us we were doing much earlier. Nowadays, you can't afford to do such. And also, their choice of a companion is giving a support to them. And that will help us to have a normal delivery also. and pain relief, whatever form, has to be given. So these are the two important things that they are stressing. Okay, so we can wait if provided everything is normal. That is all the meaning, that we will not go beyond 12 hours or 12 hours after 5-7 days. It's not required, it's not necessary also. Okay. Okay, carry on.
Let's move on to the next session. It's neonatology for the obstetricians. I would like to invite the chairpersons, Dr. Omana Madhusudan Madam, Senior Obstetrician and Gynecologist, Minor, and Dr. Christine Indumadi Madam, Senior Pediatrician and Neonatologist, SUT Hospital, Trivandrum, to chair the sessions. Over to you, ma'am.
A warm good evening to all. Now we have heard about obstetrics for the pediatrician, and now we have neonatology for the obstetricians. As you all know, whenever there is a delivery of some problem babies, we always want pediatrician or neonatologist with us in the labor room. So today I have my chairperson, Dr. Christine Indumadi. Very important topic relevant to obstetricians, NRP update, kangaroo mother care and breastfeeding, and outcome of fetal anomaly by three eminent speakers, Dr. Ananthan, Dr. Somashekar, and Dr. Linz Paul. Now, coming to NRP update. Whenever we talk about neonatal resuscitation, it is one of the topics that any healthcare provider who looks for the newborn should be aware of. Be an obstetrician, be a pediatrician, neonatologist, a staff nurse, more I say staff nurse or NIC, in the labor room or NICU, who cares for the newborn. And regarding neonatal resuscitation, it is a subject who is updated every other year. And so we have to keep on relearning neonatal resuscitation. And there is no better platform other than MILAN, when all three of us joined together in this venture. And I still remember in my student life, that is 35 years ago, under the guidance of Paili sir, Shekaran sir, or Rajagopalan sir, Mathai sir, we used to have perinatal sessions and perinatal audits. I am very glad that after years ago also, we are joining together as MILAN, which is the need of the hour. Now I invite Dr. Ananthan from Kinder Cherpala to speak on NRP updates. To Dr. Ananthan. I think he's here. Okay.
Am I audible to everyone?
Yes. Yes.
Okay. Good evening to all. As Madam rightly said, neonatal resuscitation is a very important topic. Neonatal resuscitation has saved and is saving millions of babies globally from perinatal asphyxia. So thank you, MILAN organizers, for giving me this opportunity to talk about NRP update. NRP is an educational program that introduces the concepts and basic skills of neonatal care, neonatal resuscitation. It helps the learners to learn the cognitive, technical, and teamwork skills needed to resuscitate and stabilize newborns. American Academy of Pediatrics introduced NRP first in 1987. At that time, their aim was to have a trained provider, at least one trained provider, to attend each delivery. However, the program became so successful that currently their aim is to have a trained resuscitation team, those who have enough knowledge and skill in neonatal resuscitation to attend each delivery. NRP program has been globally accepted. It is being practiced in more than 130 countries. That itself indicates how popular the program is and how useful it is for the newly born babies. Over the world, there are more than 4.5 million NRP providers, and every year 2 lakh registration is occurring. In June 2021, the American Academy of Pediatrics, in association with American Heart Association, has released the 8th edition of NRP. And this program will be implemented from January 1st, 2022 onwards. So the current 7th edition will stand cancelled from 2022 onwards. Coming to the people working behind NRP, the International Liaison Committee on Resuscitation, Neonatal Task Force, in association with the resuscitation councils worldwide, they gather evidence on resuscitation science. They collect all the systematic reviews, evidence updates, animal studies, everything, and they gather, do systematic reviews, and come up with a document called COSTAR, that is consensus on science and treatment recommendation of cardiopulmonary resuscitation and emergency cardiovascular care. From this mother document, various resuscitation councils develop their own resuscitation guidelines suiting to their unit or to their region. And NRP steering committee develops educational materials to disseminate the knowledge of neonatal resuscitation to the providers. And every 5 years, the cycle, the updates are published. The present NRP textbook, that is 8th edition, has 11 chapters, which is similar to the one we had earlier, that's 7th edition. And in addition, they have added 3 supplemental lessons to the 8th edition. That is on improving the resuscitation team performance, resuscitation outside the delivery room, and on quality improvement of the resuscitation team. So there are basically two curriculums. One is for NRP Basic or NRP Essential. That is to be learned by anyone who is involved in newborn care. Whereas the NRP Advanced is meant for people who attend complex resuscitation situations in the delivery room or OT, in an ICUs, in delivery areas, etc. We know that 85 to 90% of tame babies will start breathing within 10 to 30 seconds after birth. This transition to extrauterine life occurs without any intervention. But 10 to 15% of baby will begin breathing with some assistance like drying and stimulation. Out of this, 5% of babies will require positive pressure ventilation, and 2% require intubation for breathing. Only 0.1% will require extensive resuscitation like chest compression or emergency medications. Coming to the fetal to extrauterine transition. The two organs involved are respiratory system and cardiovascular system. We know that the placenta is the gas exchanging organ for the fetus. The fetal lung does not take part in gas exchange. So the fetal lung is filled with fluids. So the aeration which happens at the time of birth is the key event. The fluid is replaced by the air, and with the subsequent births, gradually the whole fluid is removed and lung is filled with air. Along with this, the pulmonary vessels which remain constricted in the fetal lung dilates with aeration. Along with that, the blood vessels around the alveoli dilate, the pulmonary vascular resistance drops, and the pulmonary blood flow increases. With this, it helps facilitate the cardiovascular transition also. So inside the fetus, the umbilical venous blood, which is oxygenated, which goes to the right atrium, is preferentially directed through foramen ovale into the left atrium. And from there, it goes to it bypasses the lung. And this is called right to left shunt. And the fetus brain and heart receives oxygenated blood. After birth, when the placenta is removed from the circulation, the systemic blood pressure rises. A lot of cardiovascular changes happens. One is the ductus closes, the patent foramen ovale closes, and the newborn develops the normal adult circulation pattern. So neonatal NRP provides us with the algorithm to allow us to have a proper structured resuscitation method. The algorithm describes the steps that you have to follow to evaluate and resuscitate a newborn. Throughout the algorithm, it is divided into 5 blocks, beginning with birth and initial assessment. The hexagons boxes indicate assessment. The rectangle shows actions to be taken. We have to adequately perform the steps of each block before moving on to the next block. And assessments are repeated at the end of each block and will determine if you need to proceed further. So in NRP, we usually follow the conventional airway, breathing, circulation, and drug method. Whereas in pediatrics and adults, we follow compression, airway, breathing, and circulation. So initially, we start with a rapid evaluation, followed by airway step, which includes initial steps. In the breathing part comes the positive pressure ventilation and other interventions like CPAP and supplemental oxygen. In the circulation step, we give chest compressions, and in the drug part, we give adrenaline. So this is the algorithm. So after birth comes the first assessment. We asked 3 birth questions. If the answer is no, then we move to the next step. And this is sequentially followed in the correct manner so that you don't miss any steps, and you can allow the baby to get into proper transitions safely if you follow this rhythm. So when you are called for a resuscitation, when you get a call from the labor room or obstetrician, we usually ask 3 pre-delivery questions to the obstetric provider. 4 questions, basically. First one is, what is the gestational age? Then you ask whether there is any additional risk factors like meconium or any Doppler abnormality, any cord issues like cord collapse or abruption like that. There are a lot of risk factors which we ask them. And then another question we ask is, what about the amniotic fluid? Is there meconium stain liquor or not? Or is there any blood in the amniotic fluid? And the 4th one is the umbilical cord management plan. This I have put in italics because this is the newly added change in the pre-delivery question. Earlier, in the 7th edition, it was number of babies. Now we have changed it to umbilical cord management plan. And along with that, if time permits, we can do antenatal counseling. We assemble the team and do a team briefing and equipment check. So once the team is ready, we have to identify a team leader. The team leader will designate tasks to each members. Ideally, for a normal delivery, like there will be only one person attending the delivery. But if there is any risk factors, when we ask the perinatal pre-birth question, and if there are risk factors, we need to assemble more members for the resuscitation. Ideally, there should be 4 members, one to look after the airway, the other one for circulation, one person to record the events, and one team leader who supervises the way how things are going. Then you do the equipment check, because we need to be ready with your equipments. Because if we leave it to the last moment, we will lose precious time, because most of the assessment steps will be done within few seconds. So you check whether the radiant warmer is pre-warmed or not. You check whether the oxygen supply is adequate. You connect the neopuff to the wall oxygen. Make sure the suctioning is working. You have suction apparatus, suction catheters, suction tubes. Suction machine is working. Umbilical insertion set is ready. You prepare medicines, especially the adrenaline, which is properly diluted and labeled. So these things you have to be prepared and ready before receiving the baby. So at the birth, we do a rapid evaluation of the newborn by asking 3 questions. Is the baby term or not? You do an assessment as well. You check at the baby's tone. Is it baby having good tone or floppy? And is the baby breathing or crying? If the answer to this question is yes, baby can remain with the mother. If answer to any of this question is no, then baby has to be moved to the radiant warmer for further evaluation. So a baby who is crying, has got good tone, and whose term is a low-risk baby who can remain with the mother and continue with the routine care. Whereas if the baby is preterm poor tone, no cry. It's a high-risk baby who needs further evaluation. So the next step would be the initial steps of resuscitation. There are 5 steps we do in this initial steps. Number one is the provision of warmth for the baby. Number 2 is the drying. Number 3, stimulation. Number 4 is the positioning of the head and neck. And number 5 is the clearing of secretions if needed. So the NRP has moved the stimulation part early. In the 7th edition, the stimulation was the 5th step. Now it has been brought to the 3rd step along with the drying. So if the baby is vigorous and term, you place the baby on the mother's chest, provide skin-to-skin contact. You can perform the initial steps while the baby is on the mother's chest or abdomen, and you can provide delayed cord clamping for at least 30 to 60 seconds. So after initial steps, continue your monitoring because babies can develop problems after initial cry. So you monitor the baby's tone, activity, color, temperature to see if additional interventions will be required. If the baby is non-vigorous, after the initial steps, you perform the you evaluate and you follow the algorithm methods. So in the initial steps of warming, you have to maintain the temperature. This has to be followed throughout the resuscitation. Ideally, we have to maintain the temperature between 36.5 to 37.5 centigrade. Radiant warmer is commonly used. And in preterm babies, adjunct warming methods like warm towels, cap, plastic cover, and warm mattresses can be used. Then comes the drying. Drying also helps to maintain the baby's temperature. You use the warm towel, quickly remove the baby. The drying process itself will stimulate the baby and make many of the babies cry. And if the baby is not crying, you give additional stimulation in the form of tactile stimulation by rubbing at the baby's back or flicking the stools. After that, you position the baby. This is very important. You have to, the body, neck, head should be in a straight line. We should prevent undue flexion or overextension. Ideally, this position is called neutral position or sniffing position. If the baby is having large caput or large head, it may lead to flexion of the neck. So in that situation, you can use shoulder roll to keep the head in the neutral position. The next comes the suction. Suction is needed only if there is any secretions or if you think that airway is compromised. Otherwise, no need for routine suction. And if you are doing the suction, you have to do the mouth first, then the nose. Because if you do the nose first, it will cause reflex respiratory efforts and baby can aspirate. We can use either bulb syringe or wall suction and make sure that wall suction is set at 80 to 100 millimeter of mercury. Avoid vigorous suctions. Do not stimulate the posterior pharynx because that may induce reflex bradycardia. So this is the most common scenario which we see in the labor room or theater, because after the initial steps, baby will be having a heart rate more than 100. Baby will be having increased workup breathing and baby will appear sinus. In that situation, we have to position the airway, give suction if required, apply the pulse oximeter, and provide the baby with free flow oxygen. If the baby continue to have labored breathing, you can deliver CPAP using a neopuff. And once the baby improves, we have to continue post-resuscitation care and team debriefing. Free flow oxygen can be delivered through flow inflating bag, T-piece resuscitator, or tail of the self-inflating bag. But we have to make sure that we should not place the mask firmly on the baby's face. It should be held slightly away from the baby's face to provide free flow oxygen. Nowadays, most of the units have blenders to deliver oxygen according to baby's need. To determine the baby's oxygen needs, we usually use targeted oxygen saturation tables. We need to remember only 2 numbers. One is saturation at 2 minutes of age, which is around 65 to 70%. And the other one is the saturation at 5 minutes, which will be 80 to 85. And by 10 minutes, most of the babies will be having saturation between 85 to 90. So for easy to remember, 2 minutes saturation of 65, 5 minutes saturation of 85, and 10 minutes saturation of 90 can be kept in the back of your mind. Another common situation is babies born through meconium stain liquor and who is not vigorous. The current NRP recommendation reaffirms what was done in the 2015. That is, you have to follow the initial steps. If the baby is apneic, gasping, or having heart rate less than 100 per minute, you have to proceed with positive pressure ventilation. There is no need for laryngoscopic intubation and suctioning. So the NRP is direct at this stage with this recommendation. Now comes the breathing. So if the baby is apneic, gasping, heart rate is less than 100, proceed with PPV, because ventilation of the newborn lung is the single most important and effective step in neonatal resuscitation. In the present NRP, we monitor the baby at this stage with pulse oximeter, and they have recommending cardiac monitoring to monitor for the accurate monitoring of the heart rate at this stage itself. Earlier, it was at the chest compression stage. Now they have brought it up to the breathing, positive pressure ventilation stage. Coming to the golden minute after birth. By 1 minute after birth, we should have completed the rapid evaluation, initial steps. You should have assessed the baby's respiration and the heart rate and started the first breath at the first minute of age. We can monitor the baby at this time with pulse oximeter and ECG. Studies have found that delaying the positive pressure ventilation after 1 minute will worsen the prognosis because it will be injurious to the developing brain. Now comes the assessment after positive pressure ventilation. You have started positive pressure ventilation for 15 seconds. And if the heart rate is not improving, you have to check whether the chest is rising or not. If the chest is not rising, you have to start the ventilation corrective steps, which can be easily remembered by the mnemonic MR SOPA. So you do the mask readjustment and repositioning, and then give 5 positive pressure ventilation. If the chest is not rising, you move to the next step, that is suction of the mouth and nose and opening of the mouth. You again give 5 positive pressure ventilation. If the chest is not rising, then you increase the pressure. If still pressure is chest is not rising, then you have to intubate or put a supraglottic airway and ensure that baby is on the cardiac monitor for proper accurate measurement of the heart rate. So at this point, I have to emphasize that ventilation is the key, and ventilation of the newborn lungs is the single most and effective step in neonatal resuscitation. And NRP 8th edition has given giving us a direction on the initial oxygen concentration. For a tame baby, you have to start resuscitation, positive pressure ventilation with 21% or room air. For babies less than 35 weeks, you can use between 21 to 30% of CO2. Ventilator rate is 40 to 60 breaths per minute, and the initial ventilation pressure can be up between 20 to 25 centimeter of water. And the most sensitive indicator of successful positive pressure ventilation is rising heart rate. So when you give the positive pressure ventilation, you position yourself at the head end of the baby so that you can also notice the chest rise properly. The baby should be on pulse oximeter and ECG should be in place. And you use the rhythm, breathe 2 and 3, breathe 2, 3, breathe 2, 3 for the proper delivery of positive pressure ventilation. So initial ventilation, I said, the gas flow should be 10 liters per minute, a rate of 40 to 60, pressures of 20 and 5, PEEP of 5, and oxygen as mentioned in the target saturation table. 2 important things. The mask should be properly placed on the baby's face. It should not cause pressure on the baby's eyes, and there should not be leak. You can use a single hand hold for getting proper seal. The most of the time, the leak happens between the edge of the mask and the bridge of the nose. So ensure that it is properly placed, but you should not put too much pressure on the mask because it will collapse and may close the mouth and close the airway as well. So ensure that you are giving enough pressure to have appropriate seal. Now you can use any device for giving positive pressure ventilation. Some units use ambu bag. Some units use flow inflating bag, but most of the units, the recommended one is TPs or Neopuff. The advantage is that you can deliver correct positive inspiratory pressures, and you can deliver PEEP also in this. Some situation we have to insert an orgostic tube, especially when the baby is on CPAP for prolonged period or baby is on positive pressure ventilation for several minutes. The distended stomach can hinder the ventilation. In that situation, you have to decompress the stomach by putting a orgastic tube. Now coming back to the algorithm, the circulation part, the most important step here is chest compression. If the heart rate is less than 60 births per minute, even after 30 seconds of positive pressure ventilation with adequate chest rise, you have to initiate chest compression, which should be coordinated with positive pressure ventilation at a ratio of 3:1. And at this stage, you have to give 100% FAO. We usually place that the point of compression is lower third of the chest, below an imaginary line, that is under the nipple line. You have to compress the chest firm enough that anterior the lower third of the sternum moves at least 1/3 of the anterior posterior diameter of the chest. You position yourselves at the head end of the baby, and it has been found that this position reduces the fatigueness, and also the two thumb, the rest of the fingers encircling the baby's chest is the ideal one to improve the cardiac output. And the other person, the person giving the positive pressure ventilation, can position himself at the other, on the right side, so that there is enough space for the third person to put the UVC in case we need to proceed further. So the compression is given at a rate of 90 per minute at a ratio of 3:1. To assist coordination, the person doing the compression should count the rhythm out loud, like 1 and 2 and 3 and breathe in, 1 and 2 and 3 and breathe in. This will ensure that the compression ventilation will be happening in a coordinated manner at the appropriate rate. When the heart rate is not improving with compression and ventilation, you have to remember the mnemonic cardio. Here we have to ask whether the chest is moving with each breath or not, and is the airway secured with the endotracheal tube or laryngeal mask. The rate of the compression 3:1 is delivered every 2 seconds. The depth is adequate, and is the baby on FiO2 of 100%. If not, you have to take step measures to correct this. Then, if the heart rate remains less than 60, despite 30 seconds of positive pressure ventilation through ET tube, and you have given 60 seconds of quality compressions with 100% oxygen, and you have ensured that the cardio steps is done, and still the baby's heart rate remains less than 60, you have to give adrenaline. The adrenaline dose range is 0.1 to 0.3 milligram per kg. But in the 8th edition, they have suggested a fixed dose of 0.02 milligram per kg for educational efficiency and for easy administration. And the flush volume current recommendation is 3 ml, irrespective of baby's gestation or weight. Earlier, it used to be 0.5 to 1 ml. Studies have found that if you use 3 ml, the return to spontaneous circulation is much better. And in the subsequent doses, we can repeat adrenaline every 3 to 5 minutes. And in the subsequent doses, we can increase the dose to 0.03 milligram per kg. So next step would be, if the baby is still not improving, we can consider volume expanders, especially if the baby appears shocked and if there is history of blood loss, or from the clinical examination, baby looks extremely pale due to blood loss. We can give volume expanders, normal saline, and Paxil or negative uncross matched blood can be given. The volume is 10 ml per kg. It is usually administered over 5 to 10 minutes. And if the baby is still not improving with adequate compression, ventilation, epinephrine, and volume expansion, you have to again ask the cardio questions. And in addition to that, you have to check whether the correct dose of epinephrine has been given intravenously. is the umbilical venous catheter or intraosseous needle in place, or has it been dislodged, and if there is any pneumothorax or not. You can use a transillumination or X-ray if available. So you have given adequate resuscitation for about 20 minutes, and if there is still no heart rate, at this stage you can consider stopping resuscitation. But this decision is very individualized based on patient and contextual factors. The current edition emphasizes on teamwork and communication. This because we have found that poor teamwork and communication were the most common root causes for potentially preventable infant deaths in delivery room. The confusion, inefficiency may occur because several teams of caregivers are working in a confined at the same time. And each person's skill will not be used optimally without effective coordination. So the current NRP emphasizes teamwork and communication. Also, they assess the key behavioral skills. Like when you are in the team, you are supposed to maintain professional behavior. You should have proper communication. You should identify the leader. You should be using the available resources properly. So in the current NRP provider course, they assess the behavioral skill also. So to summarize, the major changes in the 8th edition is that we have replaced the how many babies question in the pre-birth to umbilical cord management plan. We have reordered the initial steps. The stimulation has come up earlier. The ECG monitoring is recommended at the time of positive pressure ventilation or when you are planning alternate airway. The dose of adrenaline has been fixed at 0.02 milligram initial dose. The flush volume has been increased to 3 ml, and the time frame for stopping the resuscitation has been increased to 20 minutes. The American Heart Association has recommended, has given a top 10 take-home messages for neonatal life support. The neonatal resuscitation requires anticipation and preparation. Newly borns, most of the babies does not require resuscitation, and most do not require immediate cord clamping. Intubation and ventilation is the priority thing. A rise in the heart rate is the most sensitive indicator of effective ventilation. Pulse oximetry should be used to guide oxygen and meet oxygen saturation goals. Chest compression should be provided if the heart rate remains low despite effective ventilation. Heart rate response is should be recorded electrocardiographically. And if the response to chest compression is poor, if the baby remains severely bradycardy, you have to give epinephrine via intravenous route. You can also use intraosseous route if possible. And failure to respond to epinephrine in newborns is the reason we can proceed with the volume expansion. If all the steps of resuscitation has been done and baby is not breathing by, if there is no heart rate by 20 minutes, you can redirect the care. You can stop resuscitation. That's all with the NRP current updates. Thank you.
Thank you very much, Dr. Anand. That was very extensive and the very beautiful pictures which are self-explanatory. Thank you very much. Now to Christian, Dr. Christian Indumade.
Good evening, and thank you for inviting me for this very important program called MILAN, and thanks the organizers. Move on to the next topic. It is KMC. Can we, Dr. Somashekar? KMC, we know, is a kangaroo mother care, and we all have recently been hearing a lot, and we know the importance of kangaroo mother care. Dr. Suman is here. She would vouch for it. And many people have worked on that, and it has really improved and has been a part of many ICUs and almost every NICU. And we have learned the importance and how it helps in survival of even the small, tiniest babies. And of course, breastfeeding is a very, very important topic. And we know that how breast milk has saved many lives. So to talk about this important topic is Dr. Somashekar.
Dr. Somashekar has not joined us.
Okay. Then we have to move to the next topic.
Yeah.
Okay, so the next topic would be outcomes of fetal malformations, and that is by the Dr. Linz Paul. Is he there? He's a neonatologist, of Miltera Hospital, Kottayam, and we would like to hear from Dr. Linz about the outcomes of fetal malformations.
So, very good evening to everyone. Am I audible?
Yes.
Yes.
So, thank you, K4G and NNF, for giving me this opportunity to share the dais with my teachers and my seniors. I think I am the junior most among this in this session. So thank you all. So I am going to the topic for today, that is outcome of fetal malformations. So a malformed baby is something very distressing, especially to the physician or rather the gynecologist who first makes the diagnosis. So the main stress for him is he will have to decide on the management as well as the outcome of this baby. And the most important thing is he will have to convey this to the parents. And on hearing this aspect, we will have to address the grievances of the parents also. And the most important question the parents will ask the physician or the gynecologist will be, what will be like the outcome? Like, will my baby will survive? Or rather, even if the baby survives, the baby has some residual defects later. Or rather, what will be the recurrence risk in the next pregnancy in such a malformation? So, general guidelines I am just telling in whenever we deal with a malformation, like what a congenital malformation. So, first and foremost thing is we'll have to make a proper diagnosis of that malformation as well as the associated anomalies. And after that, we will have to do a proper parental counseling. And we will have to make the parents understand regarding the condition of the baby. And third thing is we will have to address their grievances, whatever concerns they have regarding the baby. Then we will have to decide whether we will have to continue the pregnancy. If it is a lethal anomaly, whether termination is possible at that point of time. And thereafter, we will have to think of some of the fetal interventions if it is possible to improve the neonatal outcome. And we'll have to plan the delivery in a center that is dedicated to handle the malformation. And the next will be the timely neonatal as well as the surgical management of that condition. And the next will be the counseling of the parents regarding the outcome of that malformation. That will be the most important thing that parents will ask regarding whatever malformation we are dealing. And then we will have to explain to the parents regarding the recurrence risk of that malformation. So with this introduction, I will just go into the topic to discuss all the malformations in neonates. It's something very difficult in a single session. I think it will take something around 2 to 3 hours to discuss all the malformations in detail. So I will just discuss some of the most common or rather the most relevant malformations of each of these systems. So coming to the first thing, as the picture we can see, this is actually a baby who is having sunset sign, and the imaging which is showing dilated lateral ventricle. So this is none other than classical hydrocephalus. So it is hydrocephalus is an increase in the CSF fluid volume irrespective of the hydrostatic or barometric pressure. So briefly onto the CSF circulation, which we all know from our physiology days. So CSF is secreted from the choroid plexus. It enters the lateral ventricles. Then through the foramen of Monro, it goes to the third ventricle. Then through the aqueduct to the fourth ventricle. And then through the foramen of Luschka and Magendie goes to the subarachnoid space and enters the circulation through the arachnoid villi. So at any level of this, if there is any block, there will be hydrocephalus. So classically, there are two types of hydrocephalus. As we all know, there is communicating and non-communicating. So coming to the antenatal diagnosis of hydrocephalus, diagnosis is made by a detailed sonological evaluation Two important parameters the obstetricians see on this antenatal ultrasound. One is the lateral ventricular bit to the hemispheric bit, which is not that significant or rather sensitive in this period of time, and it has become obsolete. And the second parameter is the ventricular diameter at the level of atrium. So normal ventricular diameter at the level of atrium is less than 10 millimeter. If it is more than 10 millimeter, it is abnormal. And if it is more than 12 millimeter, it is significant ventriculomegaly. So coming to the management of that pregnancy. So most important is, as I already discussed, the parental counseling, especially regarding the risk of the progressive ventriculomegaly. The risk is around 2.5 to 4.5%. And in some cases, this hydrocephalus can be associated with chromosomal abnormalities. So we will have to counsel regarding the importance of a fetal karyotype as well as the torch workup. And the prognosis in case of a hydrocephalus depends on the presence of associated anomalies. So if possible, we will have to do a fetal MRI at around 20 weeks. Now coming to the fetal treatment, if any available, there has been studies of percutaneous cephalosynthesis that is being done. But theoretically, till now, there is no evidence of any in utero treatment. Once the baby is born, we will have to do a detailed physical examination and a neurological examination. And we will have to do a proper neuroimaging to see what type of hydrocephalus it is, whether it is a communicating or a non-communicating hydrocephalus. And then we will have to suggest for a chromosomal analysis if possible. And surgical treatment wise, classically, hydrocephalus is treated with a ventriculoperitoneal shunt. Coming to the long-term outcomes, the outcomes basically depends on the presence of other congenital anomalies. Approximately 40 to 50% of survivors have a normal IQ, and 10% of survivors have a seizure disorder. Coming to the next anomaly, that is neural tube defect, the prototype being meningomyelocele. So neural tube defects are one of the second most common cause of mortality after congenital heart disease. And histology-wise, most commonly proposed is a folic acid deficiency and maternal alcohol, maternal smoking and all. Coming to the diagnosis part, it is classically diagnosed by the two signs. One is the banana sign and the lemon sign. In that part also, the management-wise, we proceed from the counseling, then serial ultrasounds. And then coming to the prognosis, when you have to decide on the prognosis, lower the defect, the better the prognosis. And if the pregnancy is below 24 weeks, then we can try for a medical termination. And if it is more than 24 weeks, we can opt for a fetal intervention. The fetal intervention which is available is excision of membranes and with the skin flaps that is extended laterally to close the defect. So this is just a palliative measure. It is not a definitive treatment. This is basically done to prevent the occurrence of hindbrain herniation, or rather the Arnold-Chiari malformation. And postnatally, the surgical management wise, it should be done within 24 to 48 hours. Outcome of meningomyelocele, if it is performed in a dedicated center, is excellent. The survival rate is around 95% or rather beyond, and mortality rate is near zero. And hydrocephalus is seen in around 80% of the cases of meningomyelocele. And coming to the long-term outcome basically depends on the associated anomalies, urological, neuromuscular, and orthopedic abnormalities. And the most common cause of death in meningomyelocele is Arnold-Chiari malformation. And coming to the survival wise, as I already discussed, the survival is lowest and disability is greatest when it is the sensory level is above. As the sensory level goes down, the survival is highest and the disability is lowest. Coming to the next anomaly, that is anencephaly. This is almost lethal anomaly. The incidence is around 0.3 per 1,000 live births. Female to male ratio is around 3:1 to 4:1. Classical associations are folic acid deficiency, trisomy 13, 18, Turner syndrome, and maternal hypothermia. The mean gestational age of delivery of an anencephalic baby is around 36.7 plus or minus 5 weeks. Since it is a lethal malformation, there is no role for any fetal intervention, no surgical management, and we should not resuscitate a baby with anencephaly. Coming to choroid plexus cyst, this is a very common congenital malformation that is detected in the antenatal scans, and it can be unilateral or bilateral. It can be detected as early as 11 weeks. Classically, it is associated with trisomy 18, Edwards syndrome, and also with trisomy 21. So in case of, if we find a choroid plexus cyst, we will have to do a detailed sonological evaluation to see for manifestations of trisomy 18, especially anomalies of the hands, feet, and all. There is no fetal intervention that is needed for a choroid plexus cyst. And after delivery also, there is no need for an active management of a choroid plexus cyst. We will have to see for associated syndromes like trisomy 18. The only surgical intervention that is needed is when there is an obstructive hydrocephalus which is associated. Coming to another lethal malformation, that is holoprosencephaly. Classically, it is divided to 3 types. There is alobar, semilobar, and lobar. Alobar is when we have a single common ventricle display fused thalamic. Semilobar is with incomplete division of the forebrain. And lobar is we have complete division of forebrain, but will be having associated anomalies like agenesis of corpus callosum. Holoprosencephaly is associated with various facial anomalies also. So coming to the management wise, we'll have to take a detailed history, including family history, as well as his maternal history of diabetes, ethanol intake, or torch infections. We'll have to proceed with a detailed sonological evaluation with a fetal MRI if possible. In a case of holoprosencephaly, if it is less than 24 weeks, definitely opt for an elective termination because it's a lethal anomaly. And there is no fetal intervention that is to be done in a case of holoprosencephaly. And coming to the postnatal management wise, only very milder variants of lobar holoprosencephaly survive. Otherwise, almost all the holoprosencephaly, whether it is alobar, semilobar, won't survive. So there is no need for an active resuscitation or care. So this is another congenital malformation involving the central nervous system. We can see the posterior fossa, which is enlarged and cystic with an Vermean agenesis. This is none other than Dandy-Walker malformation. So Dandy-Walker malformation, this is the main differential diagnosis. We'll have to differentiate from megacystoma magna. In that case also, treatment-wise, definitely if it is less than 24 weeks, opt for a medical termination of pregnancy. If it is more than 24 weeks, we will continue with the conservative management without any fetal intervention. And postnatally, surgical management is indicated in patients with hydrocephalus, and hydrocephalus develops in around 75% by 3 months. Typically, we do a ventriculoperitoneal shunt. Prognosis wise, it is reasonably better if it is associated with milder variants of Dandy-Walker malformation rather than the complete. And if there is associated anomalies, associated congenital abnormalities, which will increase the risk of mortality and developmental delay. So we'll just go on to a small case. This is actually a term AGA baby that was born by LSCS without any asphyxia or MSL. This baby developed respiratory failure from birth, and chest X-ray was just done postnatally was suggestive of cardiomegaly, and 2D echo done which is showing pulmonary hypertension with a high output cardiac state. So the resident actually reviewed the antenatal history. He found that it was found antenatally that there was some small cyst lesion in the brain, but it was not followed up later serially. So this was that cyst which was shining, it is glaring. It is none other than vein of Galen malformation. So vein of Galen malformation is an anomaly which has to be treated properly in a dedicated center. The treatment which is available is endovascular or transarterial transvenous embolization. The outcomes are better with endovascular technique. If there is associated hydrocephalus, there will be poor prognosis, and there is no recurrence risk of vein of Galen malformation. So with that, I will just go to some of the major cardiovascular anomalies. So first and foremost is coarctation of aorta. Typically, it can be either preductal, juxtaductal, or postductal. So in any case of a congenital cardiac malformation, we will have to proceed with a detailed fetal echocardiography to confirm the diagnosis as well as to see for any other associated cardiac malformations. Also, we will have to do a detailed sonological evaluation to see for any other non-cardiac anomalies. And coarctation of aorta is an anomaly which is associated with various chromosomal malformations. So we will have to proceed with a fetal karyotyping or FISH. And regarding the mode of delivery, it is strictly obstetric, and there is no need for a cesarean section based on the condition of the baby. There is no fetal intervention which is available for a coarctation of aorta. Once the baby is delivered, we will have to stabilize the baby medically. Then surgical treatment, which is not usually done after 6 months. But there are two exceptions. If there is a severe coarctation of aorta with severe aortic arch hypoplasia and with an associated VSD, we will have to do the surgery immediately. Prognosis wise, the operative mortality is not that much. It is very less. It is less than 5%. The chances of mortality are there if there is associated congenital cardiac anomalies, that is complex cardiac malformations, or if there is a presence of CCF. The survival rate is also excellent in case of isolated coarctation of aorta. It is around 92%. And the survival rate comes down to 44% if there is associated VSD. Recurrence risks wise, definitely there is a recurrence risk, and there is definite association with Turner syndrome and Daijo syndrome. The recurrence risk is around 2% if one sibling is affected, and it increases to around 6% if two siblings are affected. Coming to next one, that is hypoplastic left heart syndrome. Till 10 years before, this was something a very lethal anomaly, which is not at all treatable, or almost all babies with HLHs used to die. But with the newer modalities of treatment and newer modalities of care, the survival with the hypoplastic left heart syndrome has improved after surgery. It is actually increased to around 58% with the Norwood surgery, and with the primary neonatal cardiac transplantation has increased to around 76%. But the neurodevelopmental disabilities constitute around 64% in the survivors. That is something really bad. Coming to the inheritance pattern, it is mostly sporadic, and the recurrence risk is around 2% if one SIB is affected, and 6% if two SIBs are affected. Coming to the classical congenital malformation, that is tetralogy of Fallot. In this tetralogy also, we will have to do a serial fetal echocardiography, detailed 2D echography, along with detailed sonological evaluation to see for associated anomalies. Classically, tetralogy of Fallot is associated with various syndromes, Daijo syndrome, velocardiofacial syndrome, and also, if possible, we will have to do a fetal karyotyping and FISH. If it is diagnosed less than 24 weeks, especially if tetralogy of Fallot is associated with severe pulmonary stenosis and atresia, better opt for a medical termination of pregnancy. If it is diagnosed after 24 weeks, we will continue the pregnancy. We will have to do a serial fetal echocardiography to see for any congestive cardiac failure or hydrops. There is no fetal intervention that is needed in or available in tetralogy of Fallot. Once the baby is delivered, we will stabilize the baby medically. Then we will do the surgical part, either a palliative shunting or a definitive repair. Survival statistics is very excellent for tetralogy of Fallot. It is around 90%. That is a 30-year survival rate. And resurgery is very rare. That is done only if there is a RBOT obstruction or residual VSD. And as I have already discussed, TOF is associated with various syndromes. That is Daijo, Charge, Bacterial, and all. So there is a definite chance that there is definite recurrence risk. It's around 2.5% if one SIB is affected, and 8% if two previous SIBs are affected. Coming to another congenital heart disease, that is transposition of great arteries. This is the classical fetal echocardiographic image, which shows the parallel circulation in TGA. TGA also, the management is the same, similar, with the detailed fetal echocardiography and sonological evaluation. And MTP if less than 24 weeks, and if it is more than 24 weeks, we will proceed with serial echo to see for any hydrops also. And there is no fetal intervention that is needed for transposition of great arteries. Once the baby is born, we will have to see whether TGA is isolated or if it is associated with ASD or VSD. If there is no mixing, then we will have to do an immediate surgery. An immediate balloon atrial septostomy is indicated. But if the TGA has an ASD or a VSD, we can proceed with the normal medical stabilization with ventilation and PGO infusion, then proceed with surgery. But ideally, in a transposition of great vessel, TGA, we will have to do the surgery within the first 2 weeks to get a better outcome. The typical surgery is arterial switch operation, and the mortality rate with an arterial switch repair is around 5 to 8% only. And the survival is also excellent. It's around 84% at 1 month, and 5-year survival is around 82% with TGA. And the recurrence risk, it is not that much compared to tetralogy of Fallot. It is mostly sporadic. It is an isolated malformation with a normal karyotype. The recurrence risk is only 1.5% with one SIP affected and 5% with 2 previous SIPs that affected. Coming to the most common of the congenital cardiac malformation, that is ASD and VSD, both of which have excellent results post-surgery. The survival is around 92% with ASD, and with the VSD, the survival is around 86%. Definitely, there is a recurrence risk with both ASD as well as VSD, even though the inheritance is sporadic. Coming to the GI malformations, I'm just discussing the most common of the GI malformations. This is the classical X-ray, which is showing the coiling of the orogastric tube, so none other than esophageal atresia. So this esophageal atresia is classically divided into 3 types. Type C is the most commonest variant. Type C is esophageal atresia with a distal tracheoesophageal fistula. Esophageal atresia is an anomaly which is associated with various systemic anomalies, predominantly cardiovascular, around 35%, and various other GI, neurological, and genitourinary anomalies. And also we will have to see for bacterial association also. So in any case of management of a GI anomaly, most commonly the fetal ultrasound will show a polyhydramnios. And in the case of esophageal atresia, we'll see the absent stomach bubble also. This stomach bubble is absent only in pure esophageal atresia. If there's a tracheoesophageal fistula also, the stomach bubble will be present. So polyhydramnios with an absent stomach bubble is classical of pure esophageal atresia. In case of esophageal atresia suspected, we will have to do a detailed anomaly screening with a fetal echocardiography to see for associated anomalies. And if possible, we will have to proceed with a fetal karyotyping to see for any trisomies. Because of the risk of polyhydramnios, in case of esophageal atresia, there is increased risk of preterm labor. And so delivery should be definitely planned in a tertiary setup. And the mode of delivery should be purely based on obstetric indications. There is no fetal intervention that should be done for an esophageal atresia. So once the baby is born, we will have to stabilize the neonate and then proceed with the surgical management. Surgical management wise, there are 2 modalities, that is immediate primary repair and delayed primary repair. Delayed primary repair, which we classically do when the distance between the 2 segments is very high. Coming to the outcome of an esophageal atresia, it basically depends on the innervation of the distal esophageal segment, but mostly esophageal atresia is associated with increased incidence of gastroesophageal reflux, also strictures. And because of this increased incidence of gastroesophageal reflux, there is increased chance for Barrett's esophagus and esophageal carcinoma when the baby goes to childhood and adulthood. So periodic endoscopic surveillance is essential after reconstruction in case of esophageal atresia. And the recurrence risk is between around 0.5 to 2% in case one SIB is affected, and it comes to more than 20% if a second sibling is affected. So this is another anomaly. This we can see the double bubble sign, classical of duodenal atresia. Duodenal atresia is anomaly which is associated with various congenital malformation, especially trisomy 21. Around 31% cases of trisomy 21 is seen in duodenal atresia babies. And coming to the management wise also, as discussed in esophageal atresia, there will be polyhydramnios with a double bubble sign in fetal ultrasound. We'll have to proceed with the detailed sonological evaluation with the fetal echo. And there is no fetal intervention that is available for duodenal atresia. Once the baby is born, we will have to do the initial stabilization, then proceed with the surgical management. Surgical management is classically duodenostomy or duodenojejenostomy. Coming to anorectal malformations or ARMs. So anorectal malformations, it can be of two types. It can be a low ARM or a high ARM. And once the baby is born, the treatment wise in a low ARM, we can complete the surgery in a single stage with a single stage anoplasty. If the anorectal malformation is a high, we will have to do an initial colostomy, then proceed with the definitive surgery, that is posterior sagittal anorectoplasty. Prognosis is excellent if it is an isolated anorectal malformation, but in case of associated anomalies like a cardiovascular anomaly, the prognosis becomes dismal and mortality chances are there. Coming to the prototype of abdominal wall defect, that is gastroschisis and omphalocele. So omphalocele is an anomaly where there is a covering with the membrane, and gastroschisis is a full thickness hole in the abdominal wall. There is no sac covering a gastroschisis. Omphalocele is classically associated with associated anomalies, that is cardiac, renal, and various other chromosomal anomalies. This is usually not associated with other intestinal atresia, whereas gastroschisis is typically associated with congenital intestinal atresias. Prognosis wise also, if it is an isolated omphalocele, the prognosis is better than gastroschisis. The mortality with omphalocele mostly occurs due to the presence of associated cardiac anomalies. Coming to the lung malformations in brief, this is an antenatal sonological image which shows the stomach bubble in the thorax. This is none other than congenital diaphragmatic hernia. Coming directly to the prognostic factors on antenatal scan in a congenital diaphragmatic hernia, it is basically the prognosis depends on the degree of pulmonary hypoplasia, and if there is herniation of the left lobe of liver and polyhydramnios. If there is the pulmonary hypoplasia is severe and there is left lobe of herniation, the prognosis will be very bad in the case of congenital diaphragmatic hernia. And fetal intervention wise, there was something which is called fetoscopic tracheal occlusion, which was being proposed, especially in babies with congenital diaphragmatic hernia with left lobe herniation of liver. So this is it's being a fetal intervention that is being proposed in congenital diaphragmatic hernia. This is actually done in Western countries. And coming to the treatment of newborn, once the baby is born, we will have to plan the delivery of a baby with antenatal diagnosed CDH in a dedicated center. And once the baby is born, the most tendency of doctors is to do the surgery immediately in the case of congenital diaphragmatic hernia. So in any case of congenital diaphragmatic hernia, we will have to do the initial medical stabilization, which is very important. So once the stabilization is completed, we will proceed with the surgical management, which is to be done ideally after around 24 to 48 hours of medical stabilization. Long-term outcome wise, babies who have survived congenital diaphragmatic hernia, the outcomes depends on the severity of pulmonary hypoplasia. The most common morbidities which can occur in CDH survivors are BPD, reactive airway disease, sensorineural hearing loss, developmental delay, gastroesophageal reflux, and various musculoskeletal abnormalities. Mostly the recurrence risk in CDH is very low. Mostly the cases are sporadic. Coming to the next, one of the most common malformation, that is congenital cystic adenomatoid malformations. There are classically three types, type 1 and type 2, which are macrocystic, and type 3, which is microcystic. Type 1 variant is associated with the better prognosis, and type 3 variant has the worst prognosis. In CCAM also, the antenatal history as well as the evaluation are very important. In antenatal history, we will have to see for polyhydramnios and for the presence of hydrops. Presence of hydrops is indicative of a worse prognosis in case of congenital cystic adenomatoid malformation. We classically calculate a parameter which is called a CCAM volume ratio, that is CVR. If the CVR is more than 1.6, there is increased risk of hydrops. And pregnancy management wise, we will have to do a detailed fetal ultrasound along with Doppler and serial fetal echocardiography to see for any other malformations. And treatment wise, fetal treatment is available for CCAM. especially with impending hydrops that is less than 32 weeks. In macrocystic variant, we can do a thoracoamniotic shunt, fetoscopic. And microcystic variant, we can do an open fetal resection and can proceed with a lobectomy or a pneumonectomy. If the CCAM is diagnosed after 32 weeks, we'll have to proceed with an exit procedure and then proceed with the neonatal management. The neonatal treatment wise, almost all cystic adenomatoid malformation, whether it is symptomatic or asymptomatic, has to be treated. And the prognosis is excellent. And the treatment is very essential for CCAMs because even if it is asymptomatic, there is increased chance for future infection, pneumothorax, as well as malignancy. And there is no much recurrence risk for congenital cystic adenomatoid malformation. Briefly on to congenital lobar emphysema. There is another congenital lung anomaly classically affecting the left upper lobe. And antenatal diagnosis is possible with a fetal ultrasound and an MRI. Postnatally, once the baby is born, we will have to proceed with a detailed imaging, either a CT or MRI, with or without a bronchoscopy. Congenital lobar emphysema, there are two consensus of treatment. Either we can proceed conservatively, especially in asymptomatic babies, but most of the centers do a resection in case of congenital lobar emphysema. Coming to
Dr. Lynch, we have 5 more minutes. I think next speaker is also come.
Yeah.
Anyway, wind up in 5 minutes.
Yeah. The next most common is the renal malformation. Most common is hydronephrosis. Hydronephrosis is classically it is defined as more than 10 millimeter in second trimester and more than 15 millimeter in third trimester. That is severe variant. Coming to the management wise, basically it depends on the renal pelvic diameter. If it is more than 7 millimeter on the third trimester ultrasound, we will have to proceed with a postnatal evaluation with a detailed ultrasound KV at around on week 2. And if the dilatation is more than 15 millimeter with the ureteral dilatation, we'll have to follow with serial ultrasound at around 1 to 3 months. We'll have to consider for antibiotic prophylaxis. And if it is more than 50 millimeter with associated renal anomalies, we will have to definitely start antibiotic prophylaxis and proceed with other evaluations. So this is multicystic dysplastic kidney. This is another common congenital renal anomaly, which is having a good prognosis if it is unilateral. But if the contralateral kidney has associated anomaly, the prognosis will be less. The surgical management wise, we will have to proceed with a nephrectomy to avoid for future malignancy as well as hypertension. Briefly on cleft lip and cleft palate. The timing of surgery in cleft lip, should be done be around
Dr.
3
Lynch, we are running short of time.
Yeah, and just
Can you make it very brief?
Yeah. Coming to the skeletal dysplasias, almost all just dealing with the lethal variants, that is thanotropic dysplasia, camptomelic dysplasia, and osteogenesis imperfecta type 2, some of the lethal variants of skeletal dysplasia. I know this topic is very extensive, but the most important thing, which is essential in any management of a congenital anomaly, is the reassurance and the addressal of the grievance addressal of the parents. So this is actually the picture of a family where the father was affected with the Dendy-Walker malformation. 1 week later, his kid was also diagnosed as Dendy-Walker malformation, and both of them underwent surgery, and they are alive now. So thank you all.
Thank you so much, Dr. Lynch. I'm sure it's difficult to cover the entire thing, but you have made a very excellent presentation. Thank you so much. Can we move on to the next topic, which is kangaroo mother care and breastfeeding? I already have said that both the kangaroo mother care and breastfeeding have made very important changes for us, especially in the care of preterm babies. And we have none other than Professor Somashekar to talk about that. Professor Somashekar is a professor and head of the Department of Neonatology and Pediatrics. And he has also the secretary of the KMC Foundation, and he has authored many papers. Over to Professor Somashekar.
And thank you, Dr. Indumati, for the opportunity to speak. I think I'll take 15 minutes, and maybe at around 8:10 you can let me know that 15 minutes over, and then I'll wind up in 2 to 3 minutes. Thank you for the opportunity, and I will I'll share my screen.
Yeah, Dr. Lenz.
No, that's fine. That's fine. I can share the screen. So this is we'll be talking about kangaroo mother care and breastfeeding, and this is going to be the slides are mainly derived from the Kangaroo Mother Care Foundation slides. The slides were made for UNICEF, and I'll be sharing some of the slides that have been made by a lot of people, and including me. But so it's not just only me. The slides are made by KMC Foundation. So we do know the definition of kangaroo mother care, where we talk about skin-to-skin contact, which is prolonged and early, along with exclusive breastfeeding. And there are two other things which often people forget. That it includes adequate follow-up and support, and early discharge because of the KMC that is given, and initiation of practice and support. So basically, you require support and discharge, good follow-up, which are there. So this is the WHO definition of KMC, and you can use various colloquial terms to make people understand as to what is KMC, because we don't see kangaroos in Asia, and it's only in Australia, and most people would not have an idea. So we often say that it's something like the monkey baby holds the monkey mother holds the monkey baby. So that's something which is very similar. We have to understand that the kangaroo position is described as the slightly extended neck with the baby in between the breasts, and there is a direct skin-to-skin contact, and in as much vertical position as possible. While we do believe that often mothers do give KMC in the sleeping position, and with a slightly elevated chest. So that's something which we need to understand. There are various mechanisms by which KMC is supposed to work. It's mainly by when there is skin-to-skin touch, which is there. There is release of oxytocin which happens, and this relates to central stimulation of the vagus nerve or the parasympathetic nervous system, and that influences physiology and endocrinology of the infant to optimize growth and development. And this leads to several benefits of KMC. So this is one. So we discussed this. A supporting environment for KMC is one of the most important factors that we need to kind of ensure are present for the baby. So this is one of the most important parts. And AKP or the alternative KMC providers. So apart from the mother, the parents, the husband, the grandparents, or even siblings should be able to do. And this will ensure the total number of time that is there can reach around 24 hours for kangaroo mother care. Most surveys of KMC have shown that even in the hospital, they barely move around. On the mother, KMC is provided barely around 3 to 5 hours on an average, while some mothers might be able to provide around 12 hours of KMC or 14 hours of KMC. On an average, the numbers really drops significantly. Okay, so that's the components: nutrition, breastfeeding, discharge, follow-up, and so this is what I've already discussed. The minimum time for kangaroo mother care theoretically is supposed to be 60 minutes, and it's basically because of the sleep cycle that a preterm baby completes in this particular position. The sleep cycle of a preterm baby is roughly around 50-55 minutes, and that is the reason why we want KMC for at least 1 hour. But while practically suggesting it, we should suggest that at least 1.5 hours. So the process from keeping the baby in the position to removing the baby from the position, so that kind of takes care of the 30 minutes or so. And shorter durations of kangaroo position may not have that much benefits as far as mortality or brain development is concerned. While it does have benefits for pain, etc., but may not have benefits for other things. Sleep cycle is essential for sensory development of the fetus and young infant, creation of long-term memory and learning, and preservation of brain plasticity. It has been seen that when sleep is disrupted or for various reasons, the brain development is not really great at that point of time. Continuous and intermittent KMC are the two kinds of KMC that are given. Continuous is what we mean by when there is 24 hours of KMC that is happening with the baby, with some breaks that the mother gets, and at that point of time, the alternative KMC provider can be helpful in providing KMC. So some units actually have a very good amount of KMC. They, like the Nalgonda unit which is the SNCU in Telangana, does around 18 to 20 hours of KMC for most of the babies. So but it depends upon who is driving the KMC, and for it needs to become kind of a regular thing for everyone. So you could do the KMC in the mother and newborn care unit. Intermittent KMC is done for shorter periods, and while I said shorter periods of KMC does have benefit, it is mainly related to pain and other things, and not for the mortality benefit, etc. This can be given in the KMC. So this is commonly done in most places where babies are getting skin-to-skin care in the SNCU. There is a duration of KMC that is suggested between up to 4 hours, which is short KMC, extended, which is 5 to 8 hours, and long, which is 9 to 12 hours. So this, and continuous, which is more than 12 hours. So this is based on the Government of India document, and these timings are basically arbitrary and not based on any particular scientific this, but these are kind of indicators to suggest that to divide or to find out who is doing how much of KMC. It's more kind of to classify areas as to how much KMC is being given. So scope, so basically all low birth weight babies, there was discussion on whether term babies should be getting KMC, and so these are other things, but the most common places where KMC is given is in the postnatal ward, where the low birth weight babies may not be of so low weight that they require admission in the NICU, but are still eligible for KMC. The other ones are babies who are sick and in the NICU and can actually also get KMC during transport of neonates, and even when the babies go home, small babies, when they go home, they should be also getting KMC. So CPAP, transport, so all these things are possible, are happening, and are being done in various places. Okay. So this is a South African doctor who said this, that in deprived sections of society with no access to hospital care, KMC is life-saving, while in middle income groups it is cost-saving because of the early discharge that you get. And discharge can vary, early discharge can vary from 7 to 15 days depending upon how small the baby was. And this is a significant amount of cost saving for patients, at least the middle class, middle income groups. And in, one of the things that have been found out in research that has been published in the last 5 years, maybe last 10, 12 years, and more significantly, adolescent outcomes have been found, published in 2016. They found that there is better brain growth among those adolescents who have received KMC when they were premature babies. And that is even better than maybe term babies of that at that point of time. So KMC has significant indicators for brain growth, and that's something which we should be talking about. It definitely reduces neonatal mortality. A large number of babies do survive because of KMC. It has got effects on temperature regulation, sedation, and stress effects. So these are the various benefits that you can see, and how does it kind of happen. As I said in the first 2 slides, skin-to-skin touch releases oxytocin and has its various effects on the vagal nuclei, the analgesic effects, the sedation effect, neurodevelopment, and brain maturation, the improved social interaction. In the next few slides, I'll show what is temperature asynchrony, where the breast of the mother adjusts its temperature to according to the temperature of the baby. And there are anti-inflammatory effect and better immunity and better survival. So there are multiple effects of KMC. So it's even better than hormone regulating temperature. Okay, so this is lactating breast. So circulation in the skin overlying the mammary gland is increased during suckling, resulting in increased skin temperature. Makes suckling more pleasant for the pups, and this circulating oxytocin mediates cutaneous vasodilation. Temperature of the breast and chest increases not only during breastfeeding but also when milk ejection is triggered psychologically. So this is a graph of a chart in the incubator on the left hand side, and this is the graph of the baby on KMC, and this is the temperature graphs of the baby. So this is something which I want you to pay a quick attention to. Incubators cost quite a lot of money, but you can see that the temperature of the baby is varying in an incubator. While on skin-to-skin care, the temperature is more or less stable. Okay, so mother's core temperature might rise 2 degrees centigrade or even drop 1 degree centigrade in a short period of time to ensure that the baby's temperature is maintained at the normal level. So this is something which any costly equipment cannot offer. So this is something people should kind of understand, that what are the various benefits of giving KMC, and this is something which is proven by research. This is again in a South African hospital where you can find that the babies and the mother's temperatures is more or less similar once KMC starts. And in the incubator, as and the newborn, that the temperature is different. So this is another what do you say chart that shows the same thing. Okay, if there are two babies and two babies are kept on each close to each other, mother's breasts have the ability to change the thermal areas to accommodate multiple infants simultaneously. I talked about sleep earlier. It is important for development of the sensory system, long-term memory and learning, and strengthen the synaptic connections. Physiology. So the new, I'll have a few slides on IKMC trial later on. But what it basically suggests is even when unstable newborns, small newborns are given KMC early on, immediate after birth, and maintained in this position, there is improved physiological stability of the temperature, heart rate, and oxygen saturation when you start skin to skin care immediately after birth. Okay, infections are prevented. Breast milk output increases. The duration of breastfeeding increases. The duration of exclusive breastfeeding increases. So all this is proven by randomized controlled trials when KMC is given. Also reduces the incidence of hypoglycemia. I talked about this a bit. Neurodevelopment, you can see, is better. This is published in Acta Pediatrica in 2014. This is the one. This is basically studies done in adolescents. So you can see that a big person is there. So there they have looked at transmagnetic stimulation, and they have compared KMC preterm babies who received KMC when they were premature babies 18 years back and term babies who did not receive KMC, and then they gave them transmagnetic stimulation. There was lesser neurodisability among those who got KMC, and the cerebral function was better in the preterm babies. So this I've suggested. So what is the reason why KMC is so effective in improving brain development? Because it kind of gives you complete care. The baby can see the mom's eyes, can smell the mom's milk, can taste the mom's milk, touches the mom's skin, so hears the mother's voice, moves with the mom. So it's in skin to skin contact all the time. Baby feels safe, the body calms as well as the brain calms down. So these are the various ways in which kind of neurodevelopment is kind of hastened and improved. In the incubator, the body stresses also as well as the brain stresses. There is lots of noises, scary smells, bright lights. The body metabolism more survival focused, and there is later on weaker resilience in life. So these are very specific indicators which suggest that KMC is much better. Sleep pattern. Preterm babies have hardly around 10 to 20 seconds of quiet sleep when they are on the incubator, while when they go into KMC position, they can have a good sleep for at least around 55 minutes, and they complete their sleep cycle. This I will not go into details. I've discussed this. Okay, so this was it prevents around 2 lakh deaths per year, and this was the IKMC study published in May this year and done in various countries, of which India had contributed one of the largest amounts. What they found was babies got KMC right from birth, while in the control group, babies got KMC, but they got KMC after the baby became kind of a little bit stable. So that was the only difference. Both groups got KMC. It's not like one group got KMC and another group did not get KMC. So this is the mother newborn unit in Safdarjung Hospital, where mothers and babies are kept together. Okay, and they had an additional 1.5 lakh lives saved per year. So breastfeeding I have discussed. Psychology of the mother improves definitely, and it is useful to family as well as the community and the hospital as well as the nation. So I'll not go into details of this. I'll keep 2 minutes on how baby can be breastfed. So baby can be breastfed in the KMC position, where the mother can move the baby down slightly and breastfeed in that position, and this can be done as and when the baby feels that baby needs to be fed. Alternatively, the baby is small and has a tube in situ. Baby can be fed in that position by milk that was expressed earlier. Okay, so this baby can hold the baby in skin to skin contact with the mouth close to the nipple and wait until the baby is alert and opens mouth and eyes, and they can be lightly stimulated to be kept awake and alert. And if even that does not stimulate the baby, maybe express a few drops of breast milk and keep on the baby's lips so that baby starts feeding. So baby will smell and lick the nipple and open the mouth and start feeding. So it can be fed in kangaroo mother care position, and so this can be done on a regular basis. So direct breastfeeding can be started, and so I think I will stop here because I said 8:10. Yeah, we're at 8:10. So if there are any questions or any discussion, I can answer that. So manual expression of milk. So this is a video which is there. The mother is actually scratching the breast, which is not really, it's kind of pushing the breast. So that is not, this is not really great. Hind milk is better. The tube feeding or feeding the low birth weight at the top. I don't know if you can hear the audio. The express breast milk given. The Pallade can be used. Spoon feeding also can be done. And this is a baby who's feeding twin babies at the same time. Yeah, so there was this discussion on COVID pandemic. So even COVID pandemic, it was shown that if KMC was practiced, there was a reduction on KMC that was practiced. What was found was that here, if you separated the babies and the mother, then deaths reduction due to not getting COVID was 1950. But if you kept them together, then life saved by KMC was 1,25,000. So separation of babies and mothers during COVID pandemic actually increased the deaths that happened. So that was something which was quickly changed even by IAP and LNF. So I think let's stop here. Many of the slides are from Dr. Suman Rao's presentations, and thank you to her. Thanks a lot.
Thank you, sir. Thank you for the excellent talk and highlighting the importance of KMC. If there are questions, we will take. All the three talks are very wonderful. Dr. Omana?
Yes, I think especially kangaroo mother care, those who are not practicing will definitely start practicing after hearing from sir.
Thank you.
Yes. The anomalies, I think the most difficult thing is to tell to the mother and counsel the parents. What will be outcome like? That'll be the most difficult thing, especially soft markers.
So I think training the mothers and having the nurses being part of the training program and helping them understand how it is to be done does improve the KMC update. So we had done a study long time back. We found that if the people in the NIC unit are not very much involved, then KMC actually drops down. So it's very important to monitor the KMC rates on a regular basis and see if the rates are falling down. If the rates are falling down, then we go back and see what's changed and kind of improve the counseling method. So counsel the entire family and not only the mother, so that they ensure that KMC continues at home. So we did a study on whether KMC is continued at home. We found that if mothers did more KMC in the hospital, they were more likely to do KMC at home. But if they did not do so much KMC in the hospital for whatever reason, they were absolutely unlikely to do any KMC at home. And it correlates. The amount of KMC given in the hospital correlates with the amount of time KMC given at home too.
So I have one question. This is mother and the ICU concept is coming up very much.
Yeah.
As you said, 24 hours. But what happens to the mothers who, are they ready to take it up, like even when they're not so well in the first day?
There is a study, I think that's published or it's going to get published. This feedback from mothers was taken for KMC and they were very supportive and they were very happy to do it, and it is acceptable to mothers definitely. So this was done in Safdarjung Hospital, this IKMC trial, and the gynecologists are very supportive, and they kind of Dr. Pratima Mittal was, I think, part of the trial, and she recently spoke to us during our KMC premature week celebration. So she was saying that she'll get to other gynecologists and make sure that this concept spreads among even the private practitioners or other states. So the idea is to kind of go ahead and get this going. central government has identified or given MNCU guidelines for all the states, and now it's up to the states to ensure that they can change their setups in such a way that this MNCU kind of put up in various places. So even though Kerala has very low neonatal mortality, still there is a large amount of place that KMC can be improved. Many times what happens is, if you're talking about Kerala already at very like single digit neonatal mortality, what new can be done? So this is something where there is a lot of scope to do.
Yes. Thank you, sir.
Thank you very much. Thank you for the, yeah.
As usual, excellent talk by Professor Nimbalkar. It is like the topic itself is so much relevant to us when we are struggling with discussing further than from an IMR of 5 and 6. This is very, very relevant to us, and we had some discussion in this regard during the MBFHI, if some of you remember. So like one of the things, can I ask you if there is time, like the early skin to skin contact, that is, I'm not talking about the delivery room skin to skin contact, how profound is the influence of that on the upregulation of hormones like growth hormone, and then like the down regulation of hormones like corticosteroids and all, so that even such mothers, when they breastfeed subsequently, exclusive breastfeeding, you know, the sugar values will be low, but they won't land up with hypoglycemia because their breastfeeding, as it is, because of this phenomenon, it is protective, and plus the other effects like ketone bodies are being the fuel. So how profound is this hormonal this thing, the early skin to skin? Was that looked at in that study that you mentioned?
I don't think that was looked at that study, but what you say is quite right. What happens when it is exclusive breastfeeding is this initial contact is not there, the mother and baby are separated, and then when actual breastfeeding needs to be done, it is not taken up immediately by mother, and because that is not taken up and there are difficulties that are faced, then there are issues with people getting worried about feeding is not happening, etc. So if you start with skin to skin care immediately after birth and you continue with that, there are very less difficulties found in feeding the baby later on.
Excellent talk. Thank you. Thank you so much.
Thank you very much. Thank you for the opportunity. Thanks a lot.
Thank you, sir.
Bye. Bye.
So, I would like to thank the speakers and the chairpersons for the wonderful discussion. Now we shall move on to the next session on neonatal infections. I would like to invite Dr. Hari Prasad, Senior Consultant in Obstetrics and Gynecologist, Astor MIMS, Kannur, and Dr. Tony Mambili, Senior Neonatologist and Pediatrician, Lizzie Hospital, Ernakulam, for chairing the session. Over to you, sir.
Thank you very much for inviting me for this meeting to chair one session. This is the last session. You all know that the antepartum and intrapartum maternal infections can cause neonatal infections, and more NICU care and neonatal morbidity and mortality will be increased. So we have two experts. One is Dr. Beena Kumari. She will be dealing with how to manage, how to prevent the intrapartum and antepartum events which leads to neonatal infections. And Dr. Sridhar Sandhanam, who is the professor of neonatology in CMC Vellore, he will be dealing with how to manage the neonates. Over to you, Dr. Beena Kumari.
Can you see my slides?
Yes.
Okay.
Slideshow.
Okay, can you see it now?
Slideshow.
Is it visible?
Yeah, now it's visible.
Okay. Good evening, respected senior colleagues and my dear friends. So today I will be dealing with the obstetrician's perspective of prevention of neonatal sepsis. Now, before we go to the subject proper, we'll just go back to the basics. Now, first of all, the vaginal microbiome is very important. The Lactobacillus acidophilus is the bacterial predominant, and it produces lactic acid and hydrogen peroxide and produces an acidic pH. And that is the one which protects invasion of pathogenic microorganisms like Gardnerella vaginalis, Bacteroides, and HIV. And during pregnancy, what happens is there is vaginal mucosal hypertrophy and hyperemia due to estrogen, leading to increased glycogen and lactic acid. And this increases with gestational age. Now, this is a sort of protective mechanism, and maternal microbiome is an important factor in establishing normal neonatal microbiome, mainly the bifidobacteria. Now, coming to the skin flora also, the normal skin flora is Staphylococcus epididymis, which is occasionally pathogenic, but the skin also harbors infrequent, usually pathogenic organisms like Staphylococcus aureus, Streptococcus pyogenes, and Pseudomonas, which can lead to neonatal infections, especially during cesarean section. Now, coming to the maternal defense mechanisms to prevent neonatal infections, the most important is the human amniotic membrane. I should say it's a wonder membrane with the inner part of the amniochorionic membrane protects the fetus from microbial infection. Now, the amniotic membrane contains human amniotic epithelial cells, human amnion mesenchymal stromal cells, and a spongy layer which adheres to the chorion. And this expresses embryonic stem cell surface markers and pluripotency markers, and it produces extensive defense against potential pathogens. And it secretes a vast array of protective molecules. It has got anti-inflammatory activity mediated by immune cells. So due to this embryonic stem cell surface markers, it is widely used in reparative procedures in ocular surgery and neurosurgery. Another defense mechanism is by the cervical mucus plug. This contains several antimicrobial peptides, and this prevents ascending infection from the vagina to the uterine cavity. Now let's see the barrier defenses in the neonates. First of all, there are three barrier defenses. That is, one is skin, second intestinal mucosa, and third is the respiratory mucosa. The skin contains vernix, especially in the when the baby is a term neonate. It contains immune factors like antimicrobial proteins and peptides, which called as APP, which is capable of preventing invasion of the common pathogens like E. coli and Candida. Then another thing is when the outermost layer of the skin called stratum corneum, which prevents microbial invasion, maintains temperature and prevents dehydration. And in preterm newborns, the stratum corneum is not fully developed. The vernix also absent, so that there is a higher chance for developing infection, which is through the skin. In GI, mucosa is quickly colonized and contains significant repository microorganisms, namely bifidobacterium, and prolonged antibiotic treatment, hypoxia, and remote infections. So the barrier defense in neonates, the third thing is a respiratory mucosa. It is defended in utero by amniotic fluid, pulmonary APP, surfactant proteins A and D, and alveolar macrophages. There is mucus and mucociliary clearance of pathogens and debris by the epithelium of the conducting pathways. And in preterm infants, this mucociliary clearance is deficient. Now, coming to the microbiology of neonatal sepsis, there are a lot of gram-positive, gram-negative, and Candida, which causes early onset neonatal sepsis, which occurs within 72 hours, and late onset neonatal sepsis, which occurs more than 72 hours. Now, let's see what are the different methods of spread of maternal infections in the fetus. First and foremost is rupture of amniotic. The protective layer, when it is ruptured, it leads to ascending infection from the vagina. Then second is the fetal aspiration of the contaminated amniotic fluid due to ascending infection from the maternal urogenital tract. See, by anatomy, the urethra and the anal tract, anal canal is in close relation to the maternal vagina. So any infections in the urinary tract or infective organisms from the anal canal can easily colonize the vagina, and this this can lead to ascending infection. Inhalation of amniotic fluid leads to respiratory colonization, which causes pneumonia. Then the fourth one is a hematogenous spread. Any maternal infection, that is systemic infection, which occurs in the urinary tract, in the intestines, or the respiratory tract through hematogenous spread can lead to, but the infection of the amniotic fluid, it's called intra-amniotic infection. So this intra-amniotic infection can lead to PROM or PPROM, which again is can lead to infection, the neonatal sepsis. Now, these are the different methods of spread from the intestinal microflora and urinary microflora and vaginal microflora. This can lead to spread of this microbiome, and so also in skin microflora during cesarean section. Now, coming to the maternal risk factors of neonatal sepsis. Then the first and foremost is the low income group. Low income group means there is poor nutritional status, lack of antenatal care, and also poor hygienic practices like devoid of washing hands after going to the toilets, etc. All these things can lead to increased susceptibility. Then irregular ANC, lack of proper nutrition, and immunization. Immunizations are a way of transferring antibodies from the mother to the baby, which can prevent infection. Then maternal positive vaginal culture for group B streptococcus. This is very rampant in Western countries. The incidence of GBS is around 30%, and group B streptococcus is one of the cause for severe early onset neonatal sepsis. Then pre-existing maternal infections like a urinary infection, lower respiratory tract infection is an important risk factor. Once the membrane has ruptured and if the PROM is lasting for more than 18 hours, the delivery has not occurred within 18 hours, or a prolonged labor more than 24 hours, there's a 3 times risk factor for neonatal sepsis. So also PPROM and chorioamnionitis, there's a 5.5 times risk. Intrapartum maternal fever, there's a 10 times risk, and unclean vaginal examination. Then coming to the neonatal risk factors, first and foremost is prematurity. With the above said reasons, the preterm infants are at high risk for contracting infection because of the prematurity itself. So also there's a male preponderance, low birth weight less than 1,500 grams. Then hypoxia causes an insult to the immunological mechanisms of the fetus, which is 2.5 times such the hypoxic babies are prone for infection, and also the babies requiring resuscitation. Now let's see what are the preventive strategies an obstetrician can take to prevent neonatal infection. So during pregnancy, good antenatal care, that is maternal protein, calorie, and micronutrient supplementation. So this might prevent preterm labor. Again, the preterm labor, spontaneous preterm labor is one of the important causes of prematurity. So good antenatal care might prevent. And also teaching good hygienic practices to the mother so that the vaginal colonization may be prevented. Immunizations, important methods of providing appropriate antibodies to the newborn. For example, injection TT, influenza vaccination, all these can lead to prevention of infections. Then there are emerging vaccinations like Streptococcus agalactiae vaccine, that is to prevent group B streptococcal sepsis. So also pneumococcal polysaccharide and conjugase vaccine. Then treatment of infections, very important. The most common, the commonest infection during pregnancy is urinary tract infection. This includes a spectrum of infections like asymptomatic bacteriuria, acute cystitis, and pyelonephritis. And often asymptomatic bacteriuria is actually neglected or not found out. So untreated asymptomatic bacteriuria is found to be an important risk factor leading to preterm birth. So It should be diagnosed by urine cultural sensitivity at 12 to 16 weeks, and appropriate antibiotic therapy is recommended. Pyelonephritis also should be treated with broad-spectrum IV antibiotics, because not only to the baby, maternal urosepsis with the pyelonephritis is an important risk factor for maternal morbidity and even mortality. And all these systemic infections can cause intra-amniotic infections through hematogenous spread and can lead to PPRM and neonatal sepsis. Another important infection, which is commonly discussed very much, is bacterial vaginosis. What is bacterial vagina? It's not actually an infection. It's an imbalance of the vaginal flora. That is, there's a decrease in the normal lactobacillus vaginal flora, leading to an increase in the mixed aerobic flora like Ureaplasma ureolyticum, Gardnerella vaginalis, Mycoplasma hominis, Fusobacterium. And this can ascend to cervix and the membrane, or can lead to hematogenous spread, and this can lead to spontaneous preterm birth, PPROM, etc. But the problem is the antibiotic therapy does not affect the rate of preterm birth, and the Cochrane review says that routine screening of bacterial vaginosis is not recommended in low-risk women. But in those patients who are having PPROM, previous history of preterm labor, treatment of the symptomatic women is recommended. Bacterial vaginosis, the treatment is by metronidazole. Then another important and much talked about is group B streptococcus. And this is the most common cause of severe early onset sepsis. And group GBS infection presents as asymptomatic bacteriuria, maternal vaginitis, cystitis, chorioamnionitis, and postpartum endometritis. Western population, as I already told, it's around 30%. And it's significantly associated with PPROM and preterm labor. Actually, in our medical college, one of our PGs have done a thesis on GBS vaginal culture, but we found only 4.7% of the GBS, but there was 6.8% vaginal culture proving it was Klebsiella, and 15% showed E. coli culture from vagina. And no GBS infection when neonate was detected in that study. Now, if there is a GBS infection which is found out, antibiotic treatment during pregnancy is actually not recommended. The Western population usually advise screening at 36 to 37 weeks of pregnancy. And the management which is recommended is intrapartum antibiotic prophylaxis. That is during labor. So when the patient is having GBS infection, intrapartum antibiotic prophylaxis is recommended at least 4 hours prior to delivery. So the indications of intrapartum antibiotic prophylaxis is GBS carrier in the previous pregnancy, previous baby with GBS infection, GBS bacteriuria, unknown GBS status. GBS bacteriuria, you can do a urine culture and find out. Intrapartum fever more than 100.4, and those patients in preterm labor. So what do you give? So the recommended drug of choice is benzyl penicillin 3 gram IV followed by 1.5 gram 4 hourly, or cefuroxime injection 1.5 gram followed by 750 milligram 8 hourly. And if the patient is allergic to penicillin, vancomycin is recommended. So in GBS infection, induction of labor or CS is not contraindicated, and there's no evidence to prove that vaginal cleansing decreases the neonatal sepsis. So intrapartum antibiotic prophylaxis usually decreases the GBS sepsis in neonate by around 50 to 69% by various studies. Now coming to the preventive strategies during delivery. And during delivery, the most important is hand hygiene. And during this COVID era, we know what are the steps of hand wash techniques. I need not elaborate upon that, but you should know what are the 5 moments of hand washing. Hand washing, especially when you are dealing with the baby. So before touching the baby, you have to do a hand wash. By birth attendants during delivery, daily wiping of the cord with antiseptics, and after using the toilet, very, very important. After using the toilet, because there are certain commensal organisms, pathogenic organism, which is colonizing our hands, that is the E. coli, Klebsiella, Proteus, etc. So these are the common organisms which is causing neonatal infection. So after using toilet, proper hand washing is mandatory, and also after wiping the baby's bottom. So hand washing with soap and water or chlorine and alcohol for 30 seconds prevent infections of Staph aureus, Klebsiella, Proteus, etc. Acinetobacter also. So another thing is ensure clean running water. Clean running water is mandatory, and the taps which you use elbow tap. And another thing is one of the risk factors, unclean vaginal examinations, more than 3 in number. So you should have an autoclave PV sets with a small bowl with 3 cottons and 1 artery forceps for proper wiping before vaginal examination. So it should be a sterile vaginal examination. So you should have a hand wash, put on sterile gloves, and use autoclave PV sets for sterile vaginal examination. And avoid unnecessary pervaginal examination. Minimize the number of examinations, pervaginal examination. Avoid repeated intrapartum urinary catheterization. If the bladder is getting full, you encourage the patient to move about and to pass urine by herself. Then, during conduct of delivery, use always autoclave delivery set. No boiled instruments are recommended. Sterile delivery techniques and clean environment should be there, and you should use a sterile umbilical clip for and you have to for the clamping of the cord, and then you have to wipe the cut end with the betadine, povidone. Then during delivery, again the intrapartum antibiotic prophylaxis you can give. You can either give ampicillin, cefazolin, or cefuroxime 4 hours prior to delivery, and if it is allergic, vancomycin may be given. Then we usually get patients with intrapartum fever or chorioamnionitis, patient who is having PPROM with symptoms of fever, increased total count, etc. So this patient should be treated with broad spectrum antibiotics. And before starting broad spectrum antibiotics, take culture and sensitive samples from the vagina, endometrium after delivery, urine and blood. We usually, even you, suppose you are doing a cesarean section, you can always give an endometrial swab. And you have to change the antibiotic according to the culture and sensitivity. After delivery also, hand washing. That is a major method. Hand washing by the mother and the healthcare provider. So don't touch the baby without washing hands. Then second most important is early initiation of breastfeeding. The breast milk contains secretory IgA, lysozymes, WBCs, and lactoferrin, and this encourages growth of healthy lactobacilli and reduce the growth of pathogenic bacteria. Now, I was just thinking about the kangaroo mother care when the sir was talking about. Now, in the new Lexia guidelines, even before cutting the cord, the baby has to be put over the abdomen or the chest of the mother, and you have to cut the clamp unless the baby requires resuscitation. So this will enhance breastfeeding. This will, in a way, early skin-to-skin contact with the mother. That will also enhance the proper breastfeeding of the baby. Then umbilical stem chlorhexidine cleansing also can be done. Then prevention of infection during cesarean sections. How can you prevent? So good perioperative nutrition and preoperative bathing with the soap and water. So ask the patient to have a proper soap and water bath, especially on the site of incision and on the groins, vulva, and also the feet. Should be properly washed with soap and water. No preoperative shaving is now recommended. If needed, do clipping of hair, because shaving of hair again increases the risk of infection. Then antibiotic prophylaxis with cefazolin is recommended, usually 1 gram 15 to 60 minutes prior to the incision. And if the patient is obese, you need to give at least 2 grams of cefazolin as an antibiotic prophylaxis. Then skin preparation should be recommended by WHO in sepsis prevention is alcohol-based antiseptic solution, that is chlorhexidine alcohol is the recommended solution for skin preparation. Then surgical hand preparation, proper hand washing techniques, wash with soap and water and also with antiseptic solutions. That is a recommendation now. Then perioperative oxygenation if GA, and this oxygenation should be continued for 4 to 6 hours. Now, this is some of our statistics from our medical college, Kottayam. Total number of, this is over 2 years. Out of 8,032 live births, we had 17% preterm birth and 13.7% needed neonatal resuscitation. And our neonatal sepsis, we had 50 babies with the culture poor neonatal sepsis, and it amounts to 0.6%. And these are the organisms which was isolated from our babies. In 50, most of them were Klebsiella and Staph aureus, and very few E. coli and Acinetobacter. The last 2 years, no cases of Group B Streptococcus sepsis was reported from our hospital. So coming to the take-home messages, obstetricians have a key role in prevention of neonatal sepsis by correction of modifiable risk factors. Hand hygiene is the most important method of sepsis prevention. Proper antenatal checkup, clean delivery practices, and close follow-up the neonate are mandatory. Intrapartum antibiotic prophylaxis has proven to reduce the incidence of neonatal sepsis. Thank you very much.
Thank you, Dr. Beena Kumari, for that excellent and exhaustive talk on prevention of infection during the antenatal and intranatal, and also you touched on the postnatal aspect also.
Thank you.
Our time is little over, so I think we will, without, as you all know, the neonatal infection rate, to me, we've been practicing neonatology for the last 25 years here, has drastically come down. I think now, once upon a time, all deaths were due to neonatal sepsis or HIV, but that has changed. Now, very, very seldom we see neonatal infections in our unit. Anyway, to talk about this, we have a very experienced and enlightened speaker in Dr. Sridhar Sanandan, who is a professor of neonatology at CMC Vellore. And I understand that he has got an interest in neonatal sepsis and he has published papers. And I think he has published papers on Group B strep in his institution. Myself also, I have not seen a Group B strep infection here in Kochi, but I have seen it quite a lot in the West. So I think without wasting time, I would like to invite Dr. Professor Sridhar for delivering his talk. Over to Dr. Sridhar.
Thank you, Dr. Tony. I hope you can hear me.
Yeah.
Right. So I'm going to again talk mostly on, because it was prevention of neonatal infections, it is going to be mainly prevention rather than treatment. So I just thought this is repeated again, but I'll just go through a thing. As you all know, even the NICHD and Vermont Oxford network, actually now they've come to a consensus that sepsis occurring within 72 hours of birth is called as early onset sepsis. But only for Group B Streptococcus, up to 6 days of life, if Group B Streptococcus occurs, then it's called as early onset Group B Streptococcus disease. Dr. Beena Kumari has touched on this. Generally, early onset sepsis is from the maternal environment, usually from ascending infection from the birth canal. In the West, the common organisms are Group B Streptococcus, E. coli, and Listeria. In Africa and Asia, Klebsiella, Staphylococcus, E. coli. In CMC, over the last 25 years that I have collected data, E. coli and GBS have been the major organisms causing early onset sepsis. Recent past, we have got some cases of Klebsiella. We don't get Staphylococcus generally as early onset sepsis. Very rarely we get Staphylococcus. Right. So again, I'll just talk briefly on intrapartum antibiotic prophylaxis. That is giving intravenous antibiotics to mothers in labor to prevent mainly Group B streptococcal sepsis. The best scenario for giving intrapartum antibiotic prophylaxis will be if you can do universal screening for colonization. That means a rectovaginal swab for Group B streptococcus and give intrapartum antibiotics. Right. And the recommended thing by CDC and ACOG is ampicillin 2 grams IV stat and then 1 gram 4-tarlate, or failing that, benzyl penicillin. Right. What we follow, or many hospitals follow, is what is called as risk-based intrapartum antibiotic prophylaxis. Because as you can understand, we have about 14,000 deliveries a year. That means about 35,000 mothers undergo antenatal care in CMC. It is just humanly not possible thing to actually screen 35,000 mothers. And therefore, what we do is we identify certain risk factors, and in those, when those risk factors occur, we give intrapartum antibiotic prophylaxis, right? So prevention of infections, mainly, like I said, I'm going to concentrate, not mainly, almost exclusively on early onset infections, because this is a combined obstetric and neonatal topic. So in 3 headings: good practices or systems, mainly in obstetrics or perinatal care, antibiotics in labor, and vaccines, right? So risk factors for neonatal sepsis. In 2013, they identified when the mothers have lab-confirmed infection, the chances of the baby developing sepsis was 6.6-fold increased. When mothers had GBS colonization, it was even much more, 9.4, nearly 10 times chance of the baby having infections. And when the mother had various risk factors, pre-labor rupture of membranes, PPROM, or prolonged rupture, it was 2.3. And this is what we generally in India follow when we give antibiotics to the mother. So I'm just going to talk about, can you prevent neonatal infections? In the first place, can you prevent infections? Especially I'm concentrating on chorioamnionitis or intraamniotic infection. Can you prevent neonatal infections by treating maternal infections? Again, I'm going to focus on chorioamnionitis. Can you prevent neonatal infections by detecting colonization or by treating PPROM or prolonged rupture of membranes? Right. So I'm going to look at the evidence. Cochrane in 2013 looked at antibiotics in pre-labor, preterm rupture of membranes. Okay, and they proved that it reduces chorioamnionitis by 34% and reduces neonatal infection by 33%. So 2 of the questions are answered. Definitely intrapartum antibiotics when the mother has PPROM definitely helps not only in preventing chorioamnionitis and endometritis, but also in neonatal infections. When the membranes are not ruptured, but when the mother goes into preterm labor alone, will antibiotics help? I put it in red because one meta-analysis says that there is no reduction in these patients when the membranes are not ruptured, either in reduction of chorioamnionitis or in neonatal infections. There was one interesting study in Africa, that was HPTN 024, where they looked at giving antibiotics at 24 weeks. That is mainly metronidazole and erythromycin, looking at whether treatment of bacterial vaginosis and also giving ampicillin and metronidazole in labor. So 2-pronged antibiotics, whether it will reduce neonatal sepsis. It reduced vaginal colonization. That means it reduced bacterial vaginosis, but there was no reduction in preterm labor or chorioamnionitis. Therefore, giving antibiotics or treating bacterial vaginosis, unfortunately, has not proven to reduce neonatal sepsis. This is a very funny thing. There's only one study in 1996 where they gave, there's one thing that mothers who have meconium stained amniotic fluid are more prone to develop chorioamnionitis. This was a RCT where they gave antibiotics in MSAF, and they found that though the antibiotic arm, there was less chorioamnionitis in the mother. But this is only one very small study and very low quality evidence. Chorioamnionitis and sepsis, like I said, neonatal sepsis, both in histological and clinical chorioamnionitis, you can see both there is an increased incidence of early and late onset sepsis. Unfortunately, in obstetrics, there is no evidence on best antibiotic for chorioamnionitis. And this is, I think, one area where obstetricians have to do a lot of research. There is a lot of scope for research, and this was a meta-analysis in 2021. This again was an interesting concept of giving amnio infusion in chorioamnionitis and seeing whether amnio infusion will dilute the infective organisms in chorioamnionitis and thereby prevent neonatal sepsis. There was only one study and one, not an RCT, but I think a cohort study at the Cochrane in 2016 said there is insufficient evidence, but the one study showed a trend towards decreasing fever in mothers, but not chorioamnionitis, I mean, not neonatal sepsis. Another thing they said, is amnio infusion safe when the mother has chorioamnionitis already? This in 2020, they proved saying, yes, there was a large study which said, retrospective study, which proved that amnio infusion can be done. Treating colonization, like I said, the ACOG recommends rectovaginal swab for GBS at 36 to 37 weeks. In colonization rate, we were part of a multi-centric, multi-country trial between 2017 and 2020. It's not published as yet because we are still doing the antibody levels in the babies and mothers and the serotyping. And we found 20.6% colonization in mothers in CMC, 14% we found in our institution study in 2014, and 5.4 in 1982. And it's definitely proven that there is a 83% reduction of early onset GBS sepsis when mothers are found to be colonized and intrapartum antibiotics are given, and the number needed to treat to benefit is 25. That means if you treat 25 colonized mothers, you can prove 1 neonatal sepsis in the baby. Right. These are the risk factors that we found. In 2003, after I did a study on GBS, we identified certain risk factors for neonatal sepsis, and we started giving intrapartum antibiotics. After we have given intrapartum antibiotics also, we still get GBS sepsis. And therefore, we found what are the post-IAP risk factors. You still find multiple PVs as the risk factor both in pre-IAP and post-IAP era, and in post-IAP MSAF. We published this, Sumita Arun, one of your neonatologists in Believers, and we published this in JTP. Therefore, one of the primary areas I think of preventing neonatal sepsis in LMIC is number of PVs is the biggest risk factor. And there's not clean or unclean PVs. This is number of PVs itself. So this is whether in CMC, whether in wherever it is, it indirectly reflects high colonization rates in the mother. Because we are not doing colonization rates in all the mothers, universal screening, I think number of PVs increases the transmission of bacteria from the colonized state into intraamniotic fluid. Therefore, reducing number of vaginal examinations will definitely reduce neonatal sepsis. I've talked a lot about antibiotics in PPROM, in chorioamnionitis, and in colonized mothers, but there are downsides of giving widespread intrapartum antibiotics. Nearly 15% of mothers in CMC are exposed to intrapartum antibiotics. There is a potential for increase in gram-negative neonatal infections. There is a potential for increase in antibiotic resistance. And also when studies have shown that when you give amoxiclav to the mothers, there is an increase of necrotizing enterocolitis in newborn. So the take-home message is, where do antibiotics help? Definitely antibiotics in PPROM and chorioamnionitis reduces neonatal sepsis. Antibiotics in GBS colonized mothers and reducing PVs will help in reducing neonatal sepsis. What we do not know, still research is needed, is amnioinfusion in chorio and antibiotics in MSAF. No use is antibiotics in treating bacterial vaginosis for reduction of neonatal sepsis. We do not know in preterm labor whether antibiotics will help. I'll just talk briefly about few vaccinations. Like I said, my primary interest is GBS perinatal infections because we have a large number of GBS in CMC. That's the largest thing. Therefore, our primary antibiotics in neonatal sepsis has still remained crystalline penicillin and gentamicin, right? So effective GBS vaccine, maternal vaccines, right? It's estimated in 2019, a study said that it would prevent 231 infant and maternal GBS cases, 41,000 stillbirths, and 66,000 infant deaths annually. Now there are 2 vaccines, hexavalent GBS vaccine. This is against the capsular polysaccharide. It's hexavalent against serotypes 1A, 1B, 2, 3, 4, and 5, and it's in phase 2 trials. Should have actually completed phase 3 this year, but because of the COVID, it's been held up. And there are 2 protein-based vaccines which have completed phase 1 trial. A vaccine was supposed to be launched in 2022 by WHO, but now I think they are estimating that in 2023, a GBS vaccine will be. And I am personally very excited about this because, like I said, for us, GBS is the highest thing. 0.64 per 1,000 live births is the incidence of GBS sepsis. E. coli is about 0.7 per 1,000 live births, and these are our 2 biggest organisms. And in one of the studies which is still underway, where we looked at stillbirths, nearly 20% of unexplained stillbirths, the patients grew GBS in their cardiac blood, right? And we are still continuing this study. Looking at Tdap in pregnancy, unfortunately, even my obstetricians, though I keep pushing for Tdap, they are not still very thing in giving Tdap in pregnancy. One meta-analysis showed that giving Tdap in pregnancy brought down neonatal pertussis infection by 70 to 90%, 90 to 95% hospitalization in the first 3 months, and it can prevent 95% of deaths due to pertussis in the first 3 months of life. So I truly believe that Tdap can help, but few studies have shown that there can be an increased risk of chorioamnionitis in the mother, but this is very low quality evidence. But there were no increase in clinical evidence of chorio or ICU admission in the mothers. Right? Tetanus toxoid, all of us know, so I'm not going to go through this. Influenza vaccine in pregnancy, like I said, it has reduced lab-confirmed influenza in pregnancy by 70%, influenza-like illness, ILI, by 85%. This is in the pandemic H1N1 vaccine. In the seasonal flu vaccine, it only reduces lab-confirmed flu, but it does not reduce influenza-like illness in the mothers. It also has been shown to reduce preterm births by 13% and low birth weight by 8%. Will it change the infant outcome? So influenza infection from 0 to 6 months, there was a 48% reduction if the mother received vaccine in pregnancy. And there was a 72% reduction in hospitalization with influenza-like influenza in 0 to 6 months of age when the mother received vaccination. When do we give? That's very thing. When do we vaccinate a mother? If you choose to give influenza vaccine, mothers who were vaccinated in the second trimester had nearly 1.5 times, nearly or twofold higher antibody levels than mothers who are vaccinated in the second trimester. So if the obstetrician cares to give influenza vaccine, it would be better to give it in the second trimester, because both in the mother and in the baby, there was an increased titer of antibodies. Therefore, I'll just conclude with this. The good practices that I think are rectovaginal swabs in pregnancy, and I seriously believe reducing number of PVs when the mother is in labor. Antibiotics definitely in PPROM and choriamnionitis, especially using ampicillin, will help in reducing neonatal sepsis. Vaccines, again, I am trying to push for, especially Tdap and sometimes in influenza. We have recently published a study of influenza and pregnancy also, where we found that treating influenza with oseltamivir does not make any difference to either the maternal outcome or the baby outcome. And therefore, vaccine, I think, is more important in preventing rather than treating, and vaccine in GBS in case it comes. And further research, in those of you who are research-minded in obstetrics or neonatology, I think these are good areas of amnio infusion in choriamnionitis and maternal antibiotics in meconium-stained amniotic fluid, and to find the best antibiotic for chorio. Like I said, I talked a lot about antibiotics. George Bernard Shaw said, science never solves a problem without creating 10 more. And therefore, I think the obstetrician has to use antibiotics in mothers judiciously, but appropriately, right? Use it when needed, but also use it judiciously, and do not overuse antibiotics. Be cautious that intrapartum antibiotic prophylaxis may increase resistance, especially in Enterobacteriaceae. And finally, I think neonatal sepsis, like I said, the predominant thing in neonatal sepsis is going to be the obstetricians and neonatologists working hand in hand. And this should not be the way that we work in teamwork, right? And therefore, good teamwork between obstetrician, neonatologists, nurses, and microbiology lab will be vital in preventing neonatal sepsis. I'll stop with that. Thank you very much.
Thank you very much, Dr. Sridhar, for that excellent short, crispy talk. Anyway, it remains a puzzle about this group B strep. Why it's not seen in this part of the
people have started culturing group B strep in Kerala, Calcutta, and also, I think, a little bit more. It requires slightly more thing by the, I think, microbiology also, the culture techniques, I think. Then you will start. But I guess it has variations. Geographical location also varies. I agree.
Okay. Any other questions? No further, all the talks are Dr. Professor Beena Kumari, and your talks were very excellent, very informative. Now I hand it over to Dr. Suma to take over.
Thank you, speakers and chairpersons, for the excellent discussion. Now we have come to the end of today's academic sessions. Thank you one and all. Hoping to meet you all tomorrow morning at 10 a.m. We promise you another day of academic feast, which includes excellent talks on relevant topics by eminent speakers. Thank you once again.
Thank you very much.
Thank you.
Thank you and good night.
Thank you.